and therefore you switch over to VV Ecmo if persistent lung failure occurs, or VAV Ecmo. And this is just to show you the picture. You see if the left ventricular function is picking up, you can start thinking of weaning off all the patient also. Then monitoring and management of upper limb body hypoxemia. You improving cardiac function with poor lung functioning, upper body hypoxemia, and you see the saturation on the right radial artery. Management is through ventilator setting adjustment, treatment of the etiology, axillary artery cannulation as a separate perfusion line into the ascending aorta, VAV cannulation, and converting VA ECMO to VV ECMO. This is just to show you another arterial cannula being infused from the axillary artery into the ascending aorta, so that the coronaries and the cerebrals get pure blood, which is unable to come from the femoral artery cannula. Then cardiac stunning, this topic I would be covering in my second talk, but this is the very important aspect, and you require an IABP or left ventricular decompression to prevent a myocardial stunning because of over distension. So left atrial stunning, left atrial hypertension or cardiac stunning or left ventricular distension are all series of changes taking place because of over distension and dilatation of left ventricle. This is just to show you one example of a cardiac stunning. Videos. Okay, I will cover it in the second talk. V ECMO left heart sepsis, left heart thrombosis, pulmonary edema, increased left ventricular wall tension and decreased coronary flow. And the method to do a LV decompression is through an IABP impeller device, transeptal left ventricular cannulation, and atrial septostomy, or directly left ventricular apical cannulation, or LA cannulation, and non-invasively by reducing the inotrope and reducing the ECMO flow. Okay, the second topic is the cerebral hypoxia. Cerebral and coronary hypoxia is because of deoxygenated blood going in the ascending aorta. So what are the options? You look for an alternative method for cannulation. You look into the respiratory failure, look into the left ventricular ejection, and try to shift the hypoxic perfusion on the right side instead of the left side. So the diagnosis is by right radial saturations, and you consider the ventilatory adjustment, avoid better venous drainage and less left ventricular ejections, and VAV support, that is the partial VA and partial VV ECMO. You look for cerebral and lower limb perfusion by near infrared spectroscopy and to see the level of tissue perfusion and seeing the oxygen level at that level. These are the various circuits to be seen. That is the treatment for a poor perfusion or cerebral hypoxia. That is basically a VAV ECMO. Then cardiac ECMO in children, it requires a lot of experience. Isolated left ventricular failure is rare, and combination of right ventricular failure, pulmonary hypertension and hypoxia is the reason for deterioration. ECMO treat all the conditions. Management in radiology is a separate topic, but I'll just show you a few pictures. Time is short, so I cannot cover them, but this is how the radiology helps in assessing and treating the patient of ECMO. Then these are all radiological pictures for helping the patient of VA ECMO and determining the condition. This is a left atrial hypertension. You are doing a balloon atrial septostomy. Then management by the echocardiography, you monitor the cardiac function, the left ventricular distension, and you consider left ventricular venting or septostomy depending on echocardiographic parameters. So there are various things of echocardiography. This is again a separate topic in this training program. So we'll cover echocardiography in a separate talk. You see all these plots and masses only on echocardiography for VA ECMO. So successful weaning predictors are well judged by echocardiography. Then you require surveillance, because not only the patient, you have to do presumptive and sort of a weekly exercise to understand that the Ecmo is not going to create complication. So driving line surveillance, that is no folding or tension on the lines, maintain the lines along the leg axis of the patient, and there is special attention while moving the patient. Patient surveillance is to manage the lines across the leg axis from less than centimeters and check the skin aspect of the cannula at the insertion site, no bleeding, no sight of skin infection. Then patient surveillance, look for leg ischemia and reperfusion. And reperfusion line surveillance. Pump surveillance, look for any clots or micro air bubbles. Central unit surveillance to see all the parameters are running as expected. Membrane surveillance to do a daily surveillance of fibrin deposit or the clots at the oxygenator membrane. Biological surveillance of bleeding and clotting. Again, anticoagulation is a separate talk, so I will skip this aspect. Then the management of, again, bleeding and anticoagulation. This is in a separate talk, so I would just, but you have to look for clots in oxygenator. You can see a big clot of oxygen, dark brown in color in the venous side, and fibrin deposition, this yellowish in color on the venous side of the oxygenator. Then you have seen that over the time, as the number of days of Ecmo run increases, thromboembolic complications are more. So what is the criteria for changing the whole extracorporeal circuit? If there are massive depositions of fibrin clots, if there is severe hypoxia, despite FiO2 set at 100% in the device, severe thrombocytopenia, massive hemolysis, membrane rupture, pump, motor or controller dysfunction, and you see if required, you may require a systematic change after every 10 to 15 days, though this may be a luxury for us, but sudden catastrophe has to be prevented. Then weaning off from VA Ecmo, and weaning from VA Ecmo, it requires a readiness of the center to see for patient being brought out. So see the BP, see the pulse celerity, see the right radial artery PO2 levels, look for CVP and the pulmonary artery pressures. You reduce the flows and start with trial off and then decannulation and wound closure. So what are the weaning criteria? Daily transthoracic echo and maybe TEE evaluation. Weaning attempt of ECMO if there is no or low dose catecholamines. Post-transplantation, no RV failure. Then progressive reduction in ECMO flow rate by 66%, then 33%, then less than 10% to a minimum of 1 liter per minute, and stop if the mean arterial pressure is dropping. Then you clamp the IV lines by VAB or ABV criteria, and removal has to be in an OR where you remove the line surgically. The trial is a frequent evaluation by the team. You trial off with using a bridge, you maintain an adequate ACT and PTT levels, you start and stop with inotrope infusion, you increase ventilator settings, you do repeated echo, and you monitor ABG and missed venous oxygen saturations. So you have got indicators for readiness of weaning, you have got prerequisites for prior to weaning, you have got stopping criteria, and you have got predictors for successful decannulation. So there are 3 stages to it. First, reducing flows by 500 ml, then second stage, reducing flows by 1 liter for 10 minutes, and stage 3, reducing flow by to 1 liter for 10 minutes, and C4, there are no stopping criteria. And then you plan for an elective decannulation. So maximizing survival on VA ECMO, good patient selection, early implementation, high flows, optimum tissue perfusion, addition of IBP, avoid leg ischemia, prevent pulmonary edema. Conclusion, that time limitation, 15 to 21 days of a time period for a VA ECMO. Patient must remain, so my local complications are hemorrhage, embolism and acute limb ischemia. Stroke, ischemic and hemorrhagic complication has to be monitored. Pumps are highly pre and after load dependent, and if there's a non-pulsatile flow, you have to be careful about ECMO weaning off. We always say VV ECMO is better than ECMO because the cannulation is easy. There's an effect on improvement of pulmonary blood flow. There's a decreased LV afterload, increased coronary perfusion, and there are no emboli. So even in early patients for cardiac failure, we try with VE ECMO, and if not supported, we switch over to a VE ECMO. As you see over the time period, the adult cardiac ECMO has taken a big percentage as compared to 1990, where now adult ECMO, including ECPR and pediatric ECMO and neonatal ECMO, makes more than 40% of the total ECMO run in present years. And the take-home message is that VA ECMO is the keystone of adult and pediatric cardiac ECMO. Adult cardiac ECMO is getting more and more applications. Newer applications and feature of VA ECMO is phenomenal. It is a gradually competing with MCS and short-term VAD. Early application is the key to success. And VA ECMO is the most economical ECMO because it is a short run of ECMO. Thank you.
Thank you, Dr. Venkat, sir, for the beautiful talks on cannulation and VA ECMO. Sir, you are a pioneer in the field of ECMO, and your talks show these things, sir, in a very lucid presentation. So, anything you would like to summarize, sir, since you are there live? There are no questions in the chat box.
VECMO is getting more and more popular, and people are taking it as a challenge to enter into more difficult arenas of this, the more difficult problems. And now I find with increasing experience, we are able to apply ECMO to more challenging situations.
Thank you, sir. Thanks a lot. Over to Dr. Harneet. Thank you, sir.
Thank you, Dr. Venkat, for the wonderful presentation. Next on, we have Dr. Ramanathan. He's a senior consultant at National University Hospital in Singapore, and he'll be talking about hybrid ECMO and nomenclature. Sir, please. Sir, can you unmute yourself?
Yeah. Thanks, Nadeep. Can you hear me?
Yes, sir, we can hear you. Please. Sir, you're again on mute. Sir, Dr. Ramanam, you're on mute.
Can you hear me now?
Yes, sir, we can hear you.
Okay, sure. What's this? All right. Thanks, Hadib, and I sincerely thank the organizers of this track also for having invited me for this talk. Good evening, good afternoon to most of you who are logged in. Greetings from Singapore. My name is Ram. I work at National University Hospital, Singapore as a cardiac intensivist. And the talk I've been asked to present today is about hybrid ECMO. Essentially, it sounds really hi-fi when we start off talking. Okay. When we start talking about hybrid ECMO, many instances of a lot of us having heard about hybrid ECMO being used more frequently. But here I am trying to unravel some of the facts, the truths, the challenges of doing hybrid ECMO, and the situations, the special situations, the special clinical scenarios where hybrid ECMO is potentially useful, and some of the other situations where it should be potentially avoided. So let's start off with the basics. I would Hadeep, any idea how do I go to the next slide?
So can you click next? Click
No
anywhere
next.
on the slide.
I tried that. Okay, sure. So to start off with, I mean, look, I think it's prudent if we start talking about the science behind the current cannulation strategies. I mean, definitely, this is an ELSO meeting, and you guys are all familiar with what ECMO is. So I don't have a big problem convincing you about what the science behind veno-venous ECMO is and how oxygen exchange happens in veno-venous ECMO in a veno-venous ECMO circuit. So veno-venous ECMO essentially removes blood from the venous system and pumps back blood into the right atrium. So the oxygen saturation eventually that reaches the left side of the heart would be a mixture of ECMO-derived blood plus blood that goes through the lungs, which gets shunted across the lungs if the lungs are bad, or if the lungs take part in gas exchange up to a certain extent, some of the oxygenation that happens in that process. When you come to when you come to veno-venous ECMO, one way of administering veno-venous ECMO is through a double lumen cannula. And this double lumen cannula essentially allows you for upper body cannulation. So essentially, you can have a patient who does not have cannulas in the legs, which gives you the advantage of keeping the patient awake, extubated, and even mobilized for that extent. So you can have an upper body VV ECMO by virtue of having a double lumen cannula. Now, when you look at the cannulation strategy behind veno-arterial ECMO, there are a few phenomena that comes along with, and it is these phenomena that are usually offset by adding in another cannula or what we do in a hybrid cannulation. So one of the important things that veno-arterial ECMO does is collect blood from the venous system, usually through the femoral veins, send it through the oxygenator, send it through the pump, and it sends it back to the arterial side. Now you got to understand that veno-arterial ECMO, for all practical purposes, it's unphysiological because the blood flow from the cannulas is against the beating heart. So essentially, if let us say the lungs are damaged and the heart is pumping out deoxygenated blood, you would have a mix of deoxygenated blood and oxygenated blood that usually happens in the arch or the descending aorta, depending upon the performance of your heart or your myocardial function. So there is a watershed area, and this is, clinically observed as north-south syndrome or upper limb cyanosis. It has also been shown in labs using simulation experiments as to where exactly the mixing happens or the watershed area where exactly it can be depending upon the LV ejection fraction. So this is one thing that clearly makes VA ECMO unphysiological. You can also have upper body veno-arterial cannulation, just like how you have upper body VV cannulation with a double lumen cannula. Here you don't use a double lumen cannula. You take blood out of your jugular vein and you return it back to your axillary artery. So again, it offsets the watershed problem and at least your brain gets oxygenated. So these are some of the ways of offsetting the unphysiological nature of VA ECMO. However, there are certain periods of time when this can be overwhelming and you may not be able to offshoot some of these problems. And that's where, you start thinking about hybrid ECMO. So first and foremost, the most important point I want you all to take from this talk is hybrid ECMO is not a default ECMO mode. Your default ECMO mode is VA ECMO or venous ECMO. Hybrid ECMO is used only if there are potential problems with your default strategy. Now, this potential problem can be an inadequate drainage. It can be a combined cardiopulmonary failure, or it can be something like a Harlequin syndrome or an LV distension which needs to be unvented. So such scenarios will necessitate triple cannulation, or you will need additional cannulas, 3 or 4 cannulas to run your ECMO or to manage your patient on ECMO. The possible configurations that can arise depending upon where you put the cannulas can be manifold. These are some of the diagrams that I have pulled out of this particular article. It's a nice article which was published by our team in European Journal of Heart Failure a few years back, and clearly outlines the different possible configurations in addition to VV and VA. So you can have the various configurations of veno-venous returning back to arterial ECMO or arterial side. You can have other configurations too, where you have 4 cannulas, not just 3, you can have 4, and the different permutation combination of all this. Mind you, these are all theoretically possible. In clinical practice, we only use 1 or 2 of them, not all of them. I'll highlight those 2 things which we commonly use clinically, while the remaining things are all theoretical possibilities which you should be aware of. Let's say you have a patient whom you end up needing such a configuration, then you will have to start thinking about it. So, and I'll also show you towards the end of the talk an interesting case scenario where similar configurations were used, and you can understand the context in which hybrid ECMOs are used in clinical practice. Then comes the important question, why do you need additional cannulas? Now, additional cannulas are something which, as I said earlier, usually used to augment inadequate drainage. So when you have inadequate drainage and your patient is desaturating on veno-venous ECMO, you add in an additional cannula to make it veno-venous ECMO. Now, let us say a patient with veno-venous ECMO has a cardiac arrest. You have to convert this patient into a veno-arteriovenous ECMO. So essentially, the additional cannula now goes to the arterial side. Now, in the context of veno-arterial ECMO, you would need additional cannulas. Again, if there is inadequate drainage, where, you would need an additional venous cannula to drain out. In patients with Harlequin syndrome, you would end up pushing blood to both the artery and the vein so that oxygenated blood is available on the right and the left side of the heart, and the upper limb cyanosis is reduced. And of course, when you have arterial ECMO supporting your heart and you have concomitant severe respiratory failure, you would look at a similar configuration too. So the commonly used triple cannulations in clinical practice is VVV or VAV. Now, to make life simpler, essentially these cannulation techniques have now a nomenclature attached to it. So there is a way you express your cannulation strategy. And this is based on the Maastricht Treaty, which is adopted by the ELSO. So this was a position paper published sometime about 5 years back, and it clearly gives out how you need to abbreviate your cannulation strategy. So the primary draining cannula would be your first letter of your cannulation strategy. So if it is, say, VV ECMO, the first V stands for the draining cannula. The second V stands for the return cannula. Same thing with VA. So veno means drainage, and arterial means return. Now, when this is supplemented by a small letter A, it only denotes that this patient has an arterial cannula for distal perfusion. Double lumen cannulas are abbreviated as DL. And let us say when you have triple cannulations, so then you start using hyphen in between these letters. So what does the hyphen denote? Essentially, when you have VVV ECMO, it means you drain out of two veins and return back to one vein. When you have VVA ECMO or VAV ECMO, you drain out of one vein and return back to venous and the arterial side of the, when you return the blood from the ECMO. So this is in a nutshell as to what these terminologies mean and where the hyphen should be depending upon your drainage and return cannulas. I'm keeping it as simple as possible so that you understand this better. More than happy to take your questions if you have any, because a lot of these things sometimes go above your head when you talk about multiple cannulas in the body and when you have complex pathologies. So this is in a nutshell what the nomenclature or the cannulation nomenclature is. Now let's talk more about VVV ECMO. Now by default, VVV ECMO is not a hybrid mode. A hybrid mode should have arterial and venous cannula. VVV ECMO is only an additional cannula to the VV ECMO to facilitate more venous drainage, and it usually happens in a patient who otherwise desaturates despite VV ECMO. So you go on VV ECMO for refractory hypoxemia and you still desaturate, your patient still desaturates. That means you need to manage that with VVV ECMO, or one of the strategies that is used is VVV ECMO. You may also need it in the context of refractory septic shock when your cardiac output is high and your ECMO flows are not able to maintain the required 60 or 70% of the cardiac output. So you might add in an additional venous ECMO or venous cannula to facilitate more drainage and a higher flow. Now, let's come to the proper hybrid ECMO that we all do, essentially the veno-arteriovenous ECMO. Now, this is classically used in a patient who has VV ECMO and has concomitant heart failure. It's also used in a patient who has respiratory failure with VA ECMO. It is also used to offset Harlequin syndrome. Mind you, again, when we talk about hybrid ECMO, the literature surrounding hybrid ECMO is only limited to case series and small observational studies. All these studies have shown that hybrid ECMO is more challenging, has more complications, and outcomes from hybrid ECMO are poor compared to default ECMO modes. So compared to veno-venous ECMO or veno-arterial ECMO, hybrid ECMO has a higher morbidity and mortality. Hence, hybrid ECMO is not a default mode. Now, let's go back to VAV ECMO and talk more about it. Now, the technical aspects of veno-arteriovenous ECMO. We know blood is drained out of the vein and it goes back and it goes to the artery and the vein when it is returned. So, to facilitate that, you need a Y connector. So, the arterial cannula essentially gets connected to one limb of this Y connector and the venous cannula gets connected to the other limb, and this is oxygenated blood that goes through this cannula. Now, you clearly know when such a configuration happens, veins have the least resistance, so blood will tend to flow more into the venous limb than the arterial limb, and this may sometimes end up being deleterious to the patient. The patient may need more cardiac support than respiratory support. So essentially, you will have to regulate blood flow between the two limbs. And this is where, where hybrid ECMOs get more challenging. To regulate blood flow between these two limbs, you use an adjustable clamp called as the Hoffman's clamp. So a Hoffman's clamp is used to clamp one limb of this circuit so that you can regulate flows through those particular limbs depending upon the underlying condition of the patient. So if the patient has cardiopulmonary failure, and if it is predominant cardiac failure, you might want to send more blood to the arterial side. If it is a predominant respiratory failure, you may want to send blood more to the venous side. So the pathophysiology is quite simple. You can control the right and left ventricular filling separately, as well as you can regulate flows to the venous side and the arterial side on veno-arteriovenous ECMO. Now, the caveat here is when you are on a VAV ECMO, the amount of respiratory support is more predominant than a circulatory support. So if this patient were to have just VA ECMO for cardiac failure, he would receive lesser cardiac support or circulatory support on VAV ECMO. It is sometimes even half the support that he would get from VA ECMO. So the decision to go on VAV ECMO should be carefully taken after assessing the cardiac function and making sure that the existing cardiac function will be able to support the current patient pathology. Again, you need to be careful about how you clamp the cannulas or the limbs, and it's not enough that you clamp the limbs. You might have to measure the flows distal to the clamp to make sure how much blood flow goes through that particular limb. But having said that, when you have an arterial limb and a venous limb and this clamp, there should be a minimal flow of about 800 mils to 1 liter to avoid thrombus formation in any of these limbs. So you can clearly see how hybrid ECMOs are more challenging to monitor. You need more monitoring by the bedside to make sure that your distribution of blood, the oxygenated blood to the arterial and venous side, is well looked after. Now, the other configuration, again, a few case reports and a few case series so far, is the VVA ECMO. Here, it's usually blood draining from both veins and returned back to the body through the arterial cannula. It's a modification of your VA ECMO. So technically, this is a veno-arterial ECMO, except that you add in another drainage cannula to sometimes, unload the right ventricle. It's usually used in patients with congenital heart defects. Again, when I say usually, still rarely. It is also used in patients with intracardiac shunts. So, its use is very limited in clinical practice, but it helps unload right ventricle better. The principles are more or less the same. The only thing is the return cannula essentially is a single cannula, while blood drains from both the venous cannula and goes into the oxygenator. As I said, you don't have big time studies or data to say that this configuration is robust. But, as I said, it's used in highly selected adult patients and children. Now, in addition to that, as I said earlier, you can have various other configurations. You can have a veno-arterial ECMO with an additional limb to the PA. You can have a veno-venous, arterovenous return, veno-venous, veno-venous, and arterial return. So all these configurations are possible, and this is not routinely used in clinical practice. So let us not go there, or let us not deal with this in depth, because this is not something which you are not going to do on a day-to-day practice. Now, to make you understand these configurations, the importance of this configuration, I'll just take you through a case scenario. Just 1 second. So this case scenario will highlight how each of these configurations stand important, and you can also observe that sometimes when we use hybrid ECMO, it's usually transient. This is a dynamic patient state where you would need to use the hybrid ECMO transiently when you move from one form of ECMO to the other form of ECMO. So an example of how this is used in a clinical scenario. So the subsequent slides are about a 23-year-old woman who had SLE. So at 20 years of age, she was diagnosed to have severe pulmonary artery hypertension. Essentially, she had several admissions for acute cor pulmonale, and this admission around, she went on VV ECMO. So after she went on VV ECMO, the initial inciting event was sorted and her oxygenation improved. So she was posted for transplantation 15 days later. Now, when the transplant actually happened, the donor was a marginal donor. So the donor essentially had bilateral lower lobe pneumonia, and even though the arterial PF ratio was reasonable, there were intraoperative complications. Now let's go through what they did in this particular setting. So they started off with VV ECMO, which was reasonable. Now, when they took the patient to the OT for lung transplant, they converted this ECMO machine into a kind of a partial bypass machine. So what they did was they added in 2 more cannulas. One cannula essentially draining out of the pulmonary vein to facilitate operation, and another cannula draining out of the SVC side of things. So essentially, they have now drained the SVC and the PA as well as the IVC and returned blood back to the artery. So they converted this VV ECMO to a VVVA ECMO technically in the operating room. So the transplant was done. It was a difficult operation. There was prolonged bypass time. And unfortunately, as and when the transplant happened, the patient also developed primary graft dysfunction and hemodynamic instability. So they had to retain this patient on a veno-arterial blood configuration. However, to facilitate better venous drainage, and since they had cannulas both in the SVC and the IVC, they proceeded to keep this patient on VVA ECMO. Oh God, need to be quick then. So essentially, this was how they overcame that primary hemodynamic instability in the immediate postoperative period. Now, soon, as and when the heart recovered, this patient started having harlequin. So they had to convert this veno-venous arterial ECMO to veno-arterovenous ECMO. So essentially, they changed the return cannulas to facilitate oxygenated blood to the vein and the artery and overcome this transient period of pure lung dysfunction when cardiac function is recovering. And soon what they found, the lungs recovered completely. So they essentially decannulated this patient and the patient went back home. So you can clearly see, you still might end up using a few of these hybrid configurations in special situations. You don't retain them forever. And again, this is a dynamic kind of situation where you will need frequent changes of these configurations at various time points. So you need to be very diligent as to deciding on at what point you need to shift from one to the other. So that's the one big challenge that you usually face when you have patients on hybrid. To conclude, I'd just say that hybrid ECMO, even though it sounds very high funda and hi-fi, it's not a default mode. It's only a mode that you opt when your primary mode or default mode is not working. Outcomes on hybrid ECMO are generally poorer than that of VA or VV as a standalone therapy. Clearly, when you have somebody on hybrid mode, you need additional gadgets, not just to titrate flows, but also to measure flows in each of the limbs. And as I said earlier, it's usually transitional, and it's used only in specific instances for a limited period of time. I'll stop here and I'll take your questions. Thank you once again, the organizers, for inviting me for this talk. It's been a pleasure. I'm sure I'll get to see you this weekend at Ludhiana.
Thank you, Dr. Ramanathan. Thank you, sir. All of you can write your questions in the chat box and sir can take them. You made a difficult topic so easy that there are no questions.
It's either way, either they understood everything or they understood nothing, all or none. I would think it's the former. They understood everything.
Sure, sir. Over to you,
Hi,
Dr.
Lakshmi. How are you?
Thank you, sir, for the wonderful lecture. Next up, we have Dr. Lakshmi Raman. She's a professor in the Department of Pediatrics at University of Texas Southwestern Medical Center. Ma'am specializes in pediatric critical care with a particular focus on ECMO. and ma'am will be speaking on anticoagulation during ECMO. Ma'am, please.
Thank you for the introduction, and thanks to the organizers for inviting me to talk, and I'm hoping to see you all in Ludhiana over the weekend. I am going to share my screen, and it's asking me to open the privacy and security. I don't usually use WebEx, so I'm just going to click, and let me see if I can share the screen now. No. Grant access and system preferences. Okay. Cisco meetings. Okay, let me see again if it allows me to share. No.
Mr. Manoj, can you please guide ma'am how to do it?
I mean, it's I clicked on this one, but it says quit and reopen. I don't know. Does it want me to shut down? I'm not sure.
You click on share below and select the.
Yeah, but it says the privacy and security, and I have clicked on this one to allow. I have Cisco meetings will be able to record the contents of your screen until it is quit. You can choose to quit now or do it later. If I say later, also it doesn't.
Mr. Manoj,
Do you want me to?
I have already allowed, ma'am.
Yeah, it's not. It's not letting me do that. Do you want me to send it to you guys?
Can you send me the PPT? I'll share it here.
Ma'am, please try again, ma'am. Please try again.
And security. Let's see now. 1 second. Share. No, it's not letting me. I think it may be best, in the interest of time, for me and do the presentation.
Please send me.
To do that? And to whose email? Shall I send it to Harneet again?
Yeah, ma'am. Please send it to.
I just sent it to you. Sorry. Can you see if you got? Yeah. Percent. Perfect. Yeah. It's in the slide mode. Yeah, there we go. Okay. Next slide, please. Okay, so, sorry for all the confusion. I'm going to try and sum up the anticoagulation, which is a huge topic, in about 20 minutes. So bear with me if I'm going fast. So what do we know about ECMO and bleeding and complications? It's a major cause of morbidity and mortality. Why does it happen? Because contact of blood to non-biological surface leads to, it activates a massive inflammatory and coagulation response. And anticoagulation is necessary, but often it is at the expense of bleeding. So what do we know about bleeding and thrombosis? Next slide, please. So this is the report from the latest ELSO registry data that sums up the bleeding and thrombotic complications, divided into age groups of neonatal respiratory cardiac, pediatric respiratory cardiac, and adult respiratory cardiac. And I've taken just the major complications of intracranial bleed, cerebral infarct, GI hemorrhage, and surgical site bleeding. And you can, as you can see, the percentages are not insignificant by any means. Next slide, please. So this is a study that was published by Heidi a few years ago that was a multi-center study in pediatric and neonatal ECMO that looked at bleeding and clotting complications. As you can see, it was variable between the centers in terms of the bleeding and the thrombotic events. Each letter of the alphabet represents each center. But however, the impact on mortality between the centers was not significant. Next slide. And then when they examined the bleeding and the clotting complications according to the days of ECMO, they found that to be the greatest in the first few days of ECMO, and it then kind of seemed to level out, both the bleeding and the clotting complications. And often they were seen in the first few days of ECMO. Next slide, please. So if I were to sum up the hemostasis in one slide, what happens in ECMO? Immediately upon contact of the foreign surface, the coagulation cascade is initiated. You can see that platelets, neutrophils, and leukocytes are activated in addition to your factors of factor 10 and factor 7A, all of which leads to further amplification of the coagulation cascade, leading to thrombin generation. This then not only causes conversion of fibrinogen to fibrin, but also activates the factor 13, which then leads to stabilization of the clot and the covalent bonds. Next slide, please. So I think the best practice would be, if you're putting a patient on ECMO, it's a good idea to get baseline coagulation profile, because all of us know our ECMO patients are some of the sickest patients in the ICU, and often they have dysregulation of the coagulation cascade already. They can be in disseminated intravascular coagulation. If they are septic, they can have issues. If they have some liver dysfunction, all of which can lead to already disruption of your coagulation cascade. And so it is a good idea to get your baseline coagulation profile, including PT, PTT, fibrinogen, and D dimers. And what do we need to know, especially if you're practicing neonatal or pediatric ECMO, that PT and PTT may be already prolonged in neonates. And then inflammation increases the factor 8A activity, which could then shorten your PTT. Fibrinogen, we all know, is reduced at ECMO initiation, but then should stabilize after you initiate ECMO, and will be further reduced if you have DIC. D dimers often are normal, but it can be reduced in the first 24 hours, and you need to be thinking about DIC. Next slide. So what are the anticoagulants agents that we commonly use? Heparin is often the most commonly used agents. At least I think in India you typically use heparin. And why is that? It has a short half-life, it is reversible, and the primary action happens by binding to antithrombin. After binding, it increases the antithrombin inhibition of thrombin and factors such as all the factors and kallikrein. Next slide, please. But one thing to remember when you're using heparin is it does not lyse the existing thrombus. So if you already have a clot, heparin has no effect on that. And it also binds non-specifically to other plasma proteins and platelet-derived proteins. And why is that important? Because many times we often prime the circuit with using FFP, which has some plasma proteins. And many times these patients are thrombocytopenic, or often when they go on Ecmo, they become thrombocytopenic because there is consumption of platelets and then we give platelets. All of these can then result in your reduced effect of heparin because you do have other binding proteins. And the important thing to remember about heparin is that it is excreted by the kidneys. And often many of our patients, when they go on ECMO, already have some element of renal dysfunction, and then you give them diuretics, you place them on renal replacement therapy, all of which can affect your heparin metabolism. So that's very important for us to remember. Next slide. So what are the traditional ways of monitoring? So typically we use ACT, which is a bedside test. Then we can use APTT and antiferritin 10A. And I'm going to walk you through each of these tests and talk about the pros and cons of each of these tests. And at least in the United States, we have the luxury of being able to get all of these tests. And so I'm going to talk you through each of these. Next slide, please. So what is ACT? ACT it's an activated clotting time. It's a whole blood test. It's been used for decades. It's a global function test. And the big advantage is it's a point of care test, which means you can just take a drop of blood, put it in a strip, and get a number immediately without having to send it to the lab and having to wait for the results to come. And the reagents that are used to activate the agent varies between the labs, and you need to know what is used in your lab. Next slide. So as I said, the advantage is it's a low cost, it's point of care, so it's available 24/7, and you get an immediate result, so you're not waiting to see what happens by the time things may have changed at the bedside. So that is one of the big advantages of using ACT. But what are the disadvantages? It's affected by a lot of things. It's affected by anemia, hyperfibrinogenemia, thrombocytopenia, coagulation factor deficiencies, many of these things which exist in a patient who's going on ECMO. And it does not solely measure the effect of unfractionated heparin. So the way I think about it when I'm interpreting the ACT at the bedside when I have a patient on ECMO is it is really a trend. And I usually don't hang my hat on a particular number. I say, okay, this patient is running between 160 and 180 today. Suddenly, if it goes to 210, then I need to be concerned. Or if it suddenly drops to 130, then I need to be concerned. So it is usually a range that I'm looking for rather than more of the test itself. Next slide, please. What is APTT? It's activated partial thermoplastin time. It's a plasma-based test. So that is something to remember. It uses an activator, either calcium and phospholipids, and so that can also vary depending on your lab. And you have to remember in neonates and infants, they have a baseline of prolonged APTT. And so that is why we always say it is a good idea to get a baseline level and then target for 1.5 to 2 times your baseline. That's what we usually say. And recently, the point of care testing is supposed to be available and actually very reliable as well, though I don't have personal experience of using it. Next slide, please. So what are the advantages of APTT? As I said, it can be used both not only to titrate unfractionated heparin, but also for direct thrombin inhibitors. And there's a lot of use of direct thrombin inhibitors, and I'm going to show you some data about that as well. So, and as I said, point of care test is available, but it has shown to be reliable. What are the disadvantages? The baseline can be prolonged, as I said, in neonatal and pediatric population, and there can be variability in both inter and intrapatient levels. And then, even you're using direct thrombin inhibitors, one of the concerns of using APTT is that you can get what is called a plateau level, which means plateau effect, rather. Which means you can be in high direct thrombin inhibitor drug level, but your APTT is not going to change much. And that is often a concern of using just APTT in monitoring your DTIs. And that is why more and more labs are using now dilute thrombin to measure their direct thrombin inhibitors. Next step. The anti-10A is considered to be the gold standard for heparin monitoring, particularly in non-ECLS applications. And we generally target levels of 0.3 to 0.7. And we sometimes use, like for high-risk patients, we run lower levels of 0.3 to 0.5. And in low-risk patients, we say 0.3 to 0.7. And remember, anti-10A measures the effect rather than the level of the drug. And important thing to remember is that it is influenced by antithrombin level, and it does not be influenced by coagulopathy or thrombocytopenia. Next slide, please. So how do you do anti-10A? So you take a heparin activated platelet-free plasma, and then you add some 10A. So then there is binding of 10A to the existing thrombin complex. And then whatever the free 10A activity is there, then you add a chromogen to it, and that binds to the free 10A, and that is exactly what you are measuring in this. So it is a chromogen-based test, and so that is very important to remember when you're using a chromogen-based test. Anything that tints your plasma can give you a false level or falsely low level. And there are many things that can tint the plasma in Ecmo. One, when you have hemolysis, you can have tinting of plasma. If you're giving them total parenteral nutrition, including a lot of intralipids, then if your triglyceride level is high, that can tint your plasma. Or in neonates or a patient with liver failure, when you have high bilirubin content, you can have tinting of your plasma, and that can be a problem as well. Next slide. So what are the advantages and disadvantages? As I said, advantage is a specific measure of the effect of unfractionated heparin, and it is not influenced by coagulation factors and thrombocytopenia. So it really measures the effect of the drug. What are the disadvantages? Again, affected by 83 activity. And as I said, anything that tints your plasma, it becomes very unreliable. And now we do not have a point of care test available. Next slide. So when we have all of these things, then if you have hemolysis, you have a patient in liver failure, you have DIC and other coagulopathy, when you cannot use any of the tests, then what do we resort to? We usually use TEG or ROTA. And the advantage of this is it's a whole blood test. Again, it measures the interaction of clotting factors, fibrinogen, platelets, fibrinolysis, and it gives a global picture of the coagulation cascade and hence allows for a tailored transfusion management. What are the advantages? Because you can actually watch the TEG that is being done in real time. And in many centers, it is used in the trauma bay. In fact, when you have an actively bleeding patient, trauma patient, they use this in the trauma bay to monitor and tailor their transfusion needs based on the TEG or ROTA. Next slide, please. So I'm going to quickly walk you through what are the things that we measure. So really, R is a reaction time, and the initiation of fibrin formation, and this is what we measure for the heparin effect. K is the kinetic time for fibrin cross-linkage. Angle is the baseline to the slope of the clot formation. MA is the maximum amplitude, and it really measures platelet activity. And this one, LY is the time, the 30 minutes that it takes for the clot to lyse. So these are all the numbers that you look at and then decide at any given time, is your patient adequately heparinized? How effective are their platelets, and how effective is their clot strength and clot formation? Next slide, please. So when you have a difficulty in achieving target, then you define heparin resistance, because you are now having greater than average doses to achieve the therapeutic goal. But what is considered an average dose, and what is the therapeutic goal? And that is something that you have to define. Next slide, please. So in infants and in neonates and in infants, their heparin doses are much higher. So that is why typically we do a lot of neonatal, we do our neonatal Ecmo also in our pediatric intensive care unit. And so when we have neonates or infants, we actually start them at 28 units per kilo per hour. And usually I don't get concerned until they are in their low to mid 40s. Units per kilo per hour is when I start worrying about whether they are having heparin resistance or what's going on. And as I said, they can require as high as sometimes 60 units. And if you have patients in DIC and things like that, it is often helpful to have a baseline. And that is why we target a PTT of 1.5 to 2.5 times the baseline. And anti-10A, as I again mentioned, a high-risk bleeding patient versus low-risk bleeding patient, we change our targets. And then we adjust our ACT based on what the PTT and anti-10A goal is. Next slide, please. And then what are the possible reasons for heparin resistance? The first and foremost you want to think about is antithrombin deficiency, because we need antithrombin for heparin to be effective. Antithrombin levels less than 60%, high likelihood of heparin resistance, but certainly not a guarantee. So that is why we have stopped measuring the levels routinely, and we only get the levels if we are at very high doses and we still see clot burden in our circuit. Or when there is increased heparin clearance. As I mentioned early on, heparin is cleared by the kidneys. So if you're using a lot of diuretics or you're on CRRT, then you have to worry about need for whether the patient is needing increased heparin. And then when you, as I said, elevation of level of heparin binding proteins, when you're giving a lot of transfusion of plasma and platelets, then your heparin needs may go up. Or high levels of factor VIII of fibrinogen, then you have decreased baseline PTT and you may have heparin resistance. And certainly to think about disseminated intravascular coagulation when you have difficulty achieving target. That is something for you to think about as well. Next slide, please. So what is antithrombin? Antithrombin is a naturally occurring potent protease inhibitor in the coagulation cascade. The anticoagulant effect of antithrombin is accelerated at least 1,000 times in the presence of heparin. And the heparin decreases antithrombin levels by 15 to 30% with minimal clinical consequence. Next slide, please. And you have to remember, especially if you're dealing with neonates and infants, that the normal thrombin active antithrombin activity changes with age as well. I think there's a question in the chat that just popped up, and I have not paid attention to that. Somebody.
Ma'am, we can do the questions at the end.
And okay. So in term and preterm infants, you have to note that they're based on their maturity, the antithrombin levels can change as well. Next slide, please. Do I have time, or should I just skip the cases? I can just go skip the case and go to direct thrombin inhibitor.
We can go to directly, ma'am.
Yes, correct. If you want to, I think the next 3 or 4 slides are a case study. We can skip that.
Okay.
In the interest of time. Yeah. Next. So I want all of you to, sorry, can you just go back to the previous slide, please? In 2021, also published an adult and pediatric anticoagulation guideline, and I think it's a very good baseline to start, especially if you're a new program, to understand what this one is. So what does also say in terms of what are the anticoagulation monitoring that we need to do and the frequency? As I said, when you're in a resource limited environment, you need to be taking this with whatever you can do in your center. This is the general recommendation that also says we have to do, but as I said, it is depending on your center. Next slide, please. And this is often a challenge that we face because we have the luxury of obtaining all the tests. So when we obtain all the tests and they don't corroborate with each other, then you have to start thinking why. So for instance, if your anti-10A activity is low and your APTT is low, then that is simple because then you are not having enough activity, you can increase the heparin. But then if your anti-10A activity is normal and then your APTT is normal, then you don't change anything. But if your anti-10A is low and your APTT is high, then what are your considerations? You have to consider that there is probably some factor deficiency and repletion is needed with FFP or this one, and then to repeat those levels and to consider what the issue is. And if both the levels are high, obviously the answer is very simple and you want to decrease your heparin. Next slide, please. And again, also has some blood product goals and replacements. We typically say our platelet goal should be greater than 100, but often we are not able to meet that goal. And particularly we do use Ecmo for a lot of our oncology and sometimes on bone marrow transplant patients. And often that's not a goal that we can achieve. So we tend to make the goal based on the underlying patient disease process and what bleeding risks they are at, and that is how we monitor set the platelet goal for the day. And similarly for INR, if you have a bleeding patient, then your goal should be normal, so to say less than 1.5. But if it is not in a bleeding patient, then you can be a little bit generous in your goals. Similarly, fibrinogen, we say at least 150 milligrams or 1.5 gram per liter in a bleeding patient. But if you don't have a bleeding patient, then you can certainly lower your goals. And then hemoglobin, it is very interesting. It depends upon this one. I think all of us are more and more comfortable having lower hemoglobin levels. And even for venous ECMO, we don't target 13 or 14 these days. We just say 9 to 11. And one of the studies that we did, we showed that the higher your hemoglobin, you are at more risk for hemolysis because of the viscosity of your blood increases. And it is going to be very interesting. Dr. Tyagarajan is going to be leading the Department of Defense funded randomized study that is going to be soon enrolling patients where we have liberal RBC transfusion goals versus restricted RBC transfusion, where our hemoglobin, we are going to let it go as low as 7 in Ecmo patients. So hopefully he'll have some answers for us in another 5 years. And then again, antithrombin is something that we often measure levels that we do not treat unless we are worried that our heparin levels are going up. Next slide, please. So this was a nice systematic review that was done in adult patients where they looked at thrombosis and bleeding in patients where they had anticoagulation versus no anticoagulation. And it was very interesting. I would recommend that people read this paper, that they said that when they did a systematic review of all the papers and looked at circuit and patient thrombosis, it was actually comparable rates regardless of the administration of continuous systemic anticoagulation. So I'm not suggesting that you don't need to be on anticoagulation, but I think it is certainly something for us to consider, especially when you have a bleeding patient. It is certainly possible, and I think the luxury is even more in adult patients where you have bigger size cannulas, where you can maintain higher flows and reduce the amount of anticoagulation that is needed. Next slide. I'm going to shift gears a little bit and talk about direct thrombin inhibitors because it is certainly the way that many of the centers in the US are going towards, and it is certainly a drug in the horizon. How does direct thrombin inhibitor work? It directly inhibits the procoagulant and the prothrombotic actions of thrombin. It does not require a cofactor, so which is a big advantage. And not only does it acts against both free and clot-bound thrombin. So it helps to dissolve the existing clot as well. And it does not react with or produce heparin-dependent antibodies. So that's another big advantage. Next slide, please. So what are the direct thrombin inhibitors? We have a few of them, argatroban, lepirodin, and bivalirudin. And as far as I'm aware, in the United States, we have only argatroban and bivalirudin. There is no lepirodin. And as you can see, the half-life of these drugs are both argatroban and bivalirudin, which I have some experience with, is much shorter. Elimination is, especially with bivalirudin, as you can see, 80% of it is enzymatic and 20% is excreted by the kidneys. So it is very fast and very good. Monitoring, as I said, APTT and ACT. And I also mentioned some of the challenges when you use just the APTT because you can have a plateau effect. And thrombin binding is reversible. And one of the big concerns is that there is no antidote. But since the half-life is pretty short, particularly for bivalirudin, it doesn't matter because even by the time you're thinking about giving the drug and ordering the drug from pharmacy and this one, because it has got such short half-life, you're pretty much done with the drug. So that's one of the big advantages of using bivalirudin. Next slide, please. So as I mentioned, what are the advantages of bivalirudin versus heparin? It's got a shorter half-life. You don't need an antidote. You don't have to worry about it. And then it does not bind to other plasma proteins, so which is another big advantage. Next slide. This is the next couple of slides. I'm going to show a randomized study that we did in our center with a total of 30 patients. We had 14 patients in the control arm, which was heparin, and 16 patients in the intervention arm, which was bivalirudin. And we looked at their various things, and I'm going to walk you through this. As you can see, the demographics, the use in respiratory, cardiac, and septic shock patients, VA versus VV, there was no significant difference. And if you look at the hours of Ecmo, unfortunately, it so happened we had two patients who had very long runs and happened to be in the intervention arm. And that's how we ended up with very long Ecmo hours in the intervention arm. And then you can see survival to decannulation versus to discharge was not very different between the two groups. Next slide. And when we looked at it was just only 14 patients and 16 patients. And as you can see, there was already a big difference in the use of amount of packed red blood cells between the two groups. And similarly, also in the platelets, even though this was not statistically significant. There was no difference in the use of FFP or in cryoprecipitate, but certainly in PRBC and platelets. Next slide, please. And then when we looked at various complications, we did have more circuit changes in the intervention arm. And it is not clear that the increase in circuit change was because we had two patients who had really long runs. So if I were to sum up between bivalirudin and heparin, I would say bivalirudin is more towards the clotting end and heparin is more towards the bleeding end. And in my personal experience, I will say that bivalirudin is very stable. You spend very little time talking about anticoagulation. Bleeding is certainly not a big risk as I have seen, especially when we are doing procedures compared to heparin. But one of the big disadvantages is because it is enzymatically cleaved, wherever there's a low flow state, you seem to have more clotting. So for instance, in connectors and things like that, you already see clot forming. And then if you are going to be doing a clamp trial in your VA patient, you absolutely need to give heparin to the circuit. Otherwise, your circuit is going to clot off by the time you do your clamp trial. And then in our patient, luckily, we didn't have a patient with cardiac stun. But if you have a patient with cardiac stun in sepsis or in myocarditis, and they are in a low flow state, you can get what is called a smoke effect, where there is some clot formation in your LA and LV, and that is a big worry. So those are some of the disadvantages of using bivalirudin. And cost-wise, bivalirudin is at least 20 times more expensive than heparin. But because you have so many advantages of using less blood product, less number of blood tests to be done, I think overall the cost you do save, and I think that has now been published by multiple centers. Next slide, please. So this was another study that looked at comparison of bivalirudin versus heparin, whether it is safe. And yes, absolutely, people have found this to be a very safe drug. And as I said, in many centers in the United States, they are already switching to bivalirudin. I think I have only one more slide. Yeah. So in conclusion, anticoagulation certainly remains a significant challenge. Bleeding and clotting are ongoing challenges. There is no ideal test available. Heparin has been traditionally used, but I will certainly say that the trend towards direct thrombin inhibitors is certainly not only on the horizon, but it is actually being implemented in many of the centers across the United States and in Europe. And with that, I'm happy to take questions.
Thank you, ma'am, for the
Poonam, if you're
wonderful lecture.
I think Poonam was trying to say something. You're muted.
Ma'am, you're muted. Dr. Poonam, you're muted.
Okay. Excellent lecture, Lakshmi. Can I ask a question, small question?
Yes.
We've
Yes.
used bivalirudin in 4 or 5 ECMO patients, and
Mhm.
two of our patients were of HIT, and that's why we decided to use bivalirudin. All 3 were on ECMO. They were cases of pulmonary thromboendarterectomy. And patients did very well, but in one patient we had a clot. And when we had a clot, you just mentioned the clot did form in the LA as well as the RA, a smock, right? So we saw spontaneous echo contrast. Now, in such a patient, when you are weaning off ECMO at that stage, right? For 14 days, the patient has done well on bivalirudin, low dose infusion, 0.01 milligram per kg. We are tapering it off, and suddenly you see a clot in the oxygenator. When you see this clot, and the echo also shows the clot, is that the time to give heparin? You just mentioned it in your talk because this was a dilemma.
So, yeah. So what we have done is usually when we say when we go to low flow state. So if we typically use under 0.5 liters in the oxygenator. So that's kind of our cutoff because we have many neonates and pediatric patients.
Right.
And then the second thing that we use is like if you are going to do a clamp trial for VA ECMO, then just as soon as we clamp, we give 25 units per kilo of heparin to the circuit and then you open the bridge and we are running the pump. So we do that just so that the circuit itself doesn't clot off. Yeah. Those are the strategies we have used. And I mean, it's a big concern when you have a patient with a LA or LV clot in myocardial stun. What do you do? And I would be very nervous, one, to wean the flows to a point of compromising propagating the clot further. I guess if their myocardium is so stunned, they are certainly not ready for a clamp trial. You're either now having to, either having to bridge them to VAD or you have to give them time. And once their myocardium starts contracting,
Okay. Thank you, ma'am, for the questions. We are running a little late, so we can proceed to the next lecture, ma'am. Ma'am, can you please answer the
thank
questions
you all,
in the
and
chat?
looking forward Yeah,
Thank
looking
you.
forward to seeing everybody in Ludhiana, and feel free to email me the questions and I'm happy to answer the questions. Thank you.
Thank you, ma'am. Next up, we have Dr. Pranay, who is the co-director of the Ecmo program at Riddhi Vinayak Hospital, Maharashtra. He'll be speaking on ventilation strategy during Ecmo. Sir, please. Sir, you are on mute. Can you unmute yourself?
Good evening. I think we are running almost an hour late, so I'll try to finish as fast as possible. So that's an important topic of ventilation during ECMO. I have nothing to disclose. So what are the questions I'm going to address is ventilation, why we require, what is the harm if we ventilate, and what is the harm if we don't ventilate the patient? What should be the strategy, whether one strategy will fit to all, what is the best strategy, what are the guidelines says, what we should do, what we should not do, some clinical scenarios if the time permits, and best way, what is the best way out for a VNV, that what we practice usually. Okay. So all of us know why we ventilate the patient, to keep the lungs open, to sedate the patients, because there are sometimes flow issues. We get asynchronous breathing and then we don't get enough flow, so there is flow issues. So we have to sedate the patient. Prevent self-induced lung injury, because if the respiratory rate is high, we have to do that. For some backup, if something goes wrong with ECMO, I don't know, that might be just our mental satisfaction, because sometimes we get only tidal from 30 ml or 50 ml in adult patients, so might even less than 1 ml per kg. But in that scenario also, whether it's going to help us or no, but that at least gives us some satisfaction. And whatever the gas exchange, it adds into the X+1 contribution. And these are the disadvantage of ventilation: diaphragmatic dysfunction, oxygen toxicity, atelectasis, barotrauma, volume trauma, sedation effects. So all these are the disadvantage of ventilation. So if we don't ventilate, what will, and if we ventilate, what will be the problem? If we don't ventilate, the benefits will be, it will decrease the risk of ventilator-induced lung injury. But at the same time, the disadvantage maybe it can increase the self-induced lung injury. There will be anxiety of the patient as well as staff, but they are also worried that something get degenerated. And there's a increased lung opening time. So definitely lung recovery delays to some extent, because the PEEP effect goes away. So the lung will take some more time to open up. So advantage of spontaneous breathing is we can preserve the respiratory muscles, we can improve the vacuum mismatch, it will decrease the need of sedation, decrease the intrathoracic pressure, and it gives better tidal volume distribution. So then what should be the best ventilator strategy? And the answer is no, there is no best ventilator strategy as is been defined. The mode and indication of ECMO, and it depends on the patient tolerance and mode and indication of ECMO. So it can be no ventilation to full ventilation, it can be spontaneous mode to control mode, it can be awake versus prone ECMO, it can be extubation versus tracheostomy, or whether to go by driving pressures or go by plate pressure. So there are still some controversies in all of this. So initially we talked about lung protective strategy, and we came out with tidal 6, and we thought that is the best strategy with the plate pressure, and that was included in our ARDS net protocols, with keeping the plate pressure less than 26 and high PEEP and FiO2 to maintain saturation 85. But then after some time we thought that this is not the best strategy, because there is a concept like baby lungs concept. The lungs are very small in volumes, which is functioning. So we came out with an ultra protective ventilation strategy with the tidal less than 4 ml, plate pressure 20 to 25, PEEP of 10, and respiratory rate anywhere between 4 to 13. And this is what the strategy usually we follow as ARDS net protocols at this stage. But the controversy is the mode of ECMO. There are still a lot of controversy about what should be the mode of ventilator we should use, whether it's control mode versus spontaneous mode versus bivent or APRV versus NAVA. So there are a lot of controversies about this mode. And that still same controversy we found that with the guidelines again. In ELSO guidelines, they talk about pressure control mode, while the European Network Mechanical Ventilation VEVA study, they talked about volume control modes. So the volume control modes are always question which kind of mode is there. Scissor trial is used as a pressure control mode, while Euler trial, which has come up recently, they have used the volume control mode along with the APRV. So, which mode should be the best? Still, there is a controversy about this. If you talk about ELSO guidelines, which was in 2017, they have said about is first 24 hours is pressure control ventilation with peak pressure of 25 and peak of around 15, inverse I ratio, respiratory rate as low as 5 and FI to around 50%. 24 to 48 hours, they talk that you can decrease the pressure control to 20 and PEEP to 10. So initially, because you keep PEEP on higher side, because patient are already on high PEEP, suddenly if decrease the PEEP, it will de-recruit. And after 48 hours, minimum no sedation, and try to keep the patient on spontaneous breathing if possible. And this think about tracheostomy versus extubate if within 3 to 5 days the patient is stable. So you have to take a call depending on the patient's condition at that time. Recruitment manual should be tried only when the X-ray is improving or when the X-ray or when the tidal is improved to more than 4 cc. Otherwise, there is no point or giving the recruitment manual. Now, because they are the gas exchange entirely depend upon ACLS, we are not worried about the mechanical gas exchange as far as mechanical ventilation is concerned. So we can always think of keeping the patient ambulated and try to get the patient off ventilator at least. And almost the same guidelines for the neonates. Peak inspiratory pressures is around between 15 to 25, PEEP of 5 to 8. Respiratory rate higher side 12 to 20, and FI to 21 to 30. Okay, that's some of the centers even use APRV mode for even neonates also. So what is definite to do is we want to prevent the lung injury.
Dr. Pranay? Dr. Pranay, I think you got disconnected. I think sir got disconnected. He's trying to reconnect. Sir is trying to reconnect. I think he got disconnected. So, Dr. Mona Lisa, can we continue with your? We can. Dr. Mona Lisa?
Hi. Do you want to, are you sure should I start or should we call sir and find out?
Sir will take some time, ma'am. You can start, then we can continue the
Okay,
session.
okay, sure. Just 1 second. Should I start sharing my screen?
Yes, ma'am.
Yeah, okay. Is it visible?
Yes, ma'am. Please continue.
Perfect. Okay. So my topic is going to be relatively slightly simpler, I think. I'm going to talk about sedation and analgesia in Ecmo. So let's start. I'm not going to take more than 15 minutes. I'm going to try finishing it in time. So what are the sources of pain in Ecmo? So these big fat cannulas which are there, which are inserted to us, there might be 21 French to 27 French. So that can be a source of pain in ECMO. A lot of catheters which are put to the patient, as you can see, can be a source of pain. ET tube, pre-existing patient conditions, bed sore, nursing care, suctioning, sampling, frequent sampling, immobilization in bed. So all these can be source of pain in ECMO. So what does pain do? What is the consequence of pain? Now, pain can cause a lot of sleep deprivation, can cause a lot of agitation, sprinting, stress response. It can also cause autonomic system stimulation, tachycardia, hypertension, increased oxygen consumption, increased hypercoagulability, altered humoral response, leading to increase in factor VIII, fibrinogen, and platelet activity. It can also lead to immunosuppression, psychological disturbances like delirium, PTSD, anxiety, hallucination. So we need to deal with this pain associated with ECMO. Now, what happens in ECMO in critical illness? We need to understand about what the critical illness and ECMO does to your body to understand that what it will do to the drugs which you're going to give to the body. So when the patient is critically ill, you have augmented cardiac output, which leads to increased clearance of drugs. Similarly, you're giving loads and loads of volume to the patient. And also because of sepsis, there's a lot of leaky capillaries, which will lead to increased volume of distribution. Now, both of these are going to decrease your plasma concentration of the drugs. There is also a lot of altered protein binding. So what are the two most important proteins which we know of, which are going to which are responsible for drug metabolism? One is alpha-1 acid glycoprotein and one is albumin. Now, what happens to albumin in critical illness? It decreases. Why? Because there is increased in catabolism and decreased production. Similarly, what happens to alpha-1 acid glycoprotein? So that increases because it's an acute phase reactant. Now, what will happen to the drugs which are dependent on albumin, now which are highly protein bound? The unbound fraction of those drugs increases, as a result of which it will lead to drug toxicity. So we need to be careful about that. We need to keep in mind the increased plasma concentration of the drugs. There's also a lot of end organ dysfunction which is associated with critical illness. Now, what are the organs which we are talking about here? The mainly two organs which we are talking about here, which are responsible for drug metabolism, is liver and kidneys. So which will also lead to decreased clearance, as a result of which there'll be increased plasma concentration of the drug. Similarly, what does ECMO do? ECMO leads to augmented cardiac output, increased clearance. It also causes hemodilution. Now, how? When you initiate ECMO, you're going to use a lot of priming solution. Let it be plasma, let it be saline, let it be albumin, no matter what. That is going to cause a lot of hemodilution. Now, what is that going to do? That is going to increase your volume of distribution. Now, when the volume of distribution increases, which type of drug gets affected? So the hydrophilic drugs, which have a lower volume of distribution, they will be affected because there will be decreased plasma concentration of those drugs, as a result of which what will happen? There will be therapeutic failure of those drugs. Also, there is a lot of drug sequestration. Now, where does this drug sequestration take place? There is tubing, there is oxygenator, there is cannulas. Everywhere the drug sequestration can take place, which will also lead to decreased plasma concentration of the drugs. So these are the factors which are going to affect and cause decreased plasma concentration of the drug. Similarly, as in critical illness, ECMO will also lead to end organ dysfunction like kidney dysfunction, liver dysfunction, impair clearance of the drugs, and this decreased clearance can also lead to increased plasma concentration of the drugs. Now, what factors we need to keep in mind after understanding the pathophysiology of ECMO and critical illness, what it does to your body, what things we need to keep in mind? So these are the factors which are going to influence the pharmacokinetics of the drugs you're going to give to the patient. So ECMO-related factors, drug-related factors, and patient-related factors. Now, what are the ECMO circuit-related factors? Now, you have the circuit cannula, you have the PVC tubing, you have the centrifugal pump, you have an artificial membrane for gas exchange, which is known as the membrane oxygenator. All of this can actually cause a lot of drug sequestration. And also the circuit priming, as we discussed, when you prime the circuit, when you start ECMO, that actually causes a lot of hemodilution, which is going to affect the hydrophilic drugs, which have a lower volume of distribution. And the circuit age, that is also going to play an important role in deciding the pharmacokinetics of the drugs, and the alterations in blood flow that is caused when the patient is initiated on ECMO. Apart from that, there are a lot of drug-related factors also, like what? Like whether it's a lipophilic drug or a hydrophilic drug. Now, the volume of distribution, the protein binding, all depend upon how the drug is going to be treated in your body. Also, there are a lot of patient-related factors like your volume status of the patient, the protein concentration, as we discussed, the albumin and the alpha-1 acid glycoprotein. Also, the systemic inflammation and organ dysfunction, the liver and kidney dysfunction, mainly, which are important to responsible for your drug metabolism and elimination. So these are the factors which actually influence the pharmacokinetics of the drugs. Now, the ECMO circuit, which we talk about. Now, the extracorporeal circuit mainly consists of the cannula, the PVC tubing, the polyvinyl chloride tubing, a centrifugal pump, and an artificial membrane for gas exchange, right? So the membrane oxygenator and the PVC tubing comprise of a large surface area, which is causing a big potential of for drug sequestration, which may lead to a lot of drug loss over time, especially the lipophilic drugs. And the composition of triatubing and membrane oxygenator can also play a very important role in the amount of drug that is being sequestered. Some studies actually have observed that both the PVC tubing and the membrane oxygenator do absorb drug to similar extent, but some studies are showing that there are difference between the two. And also it depends upon the age of the circuit and the type of pump used. So these are the circuit related factors which actually cause a lot of drug sequestration, and mainly of the lipophilic drugs. So these are the pharmacokinetic alterations that happen during ECMO. Altered volume of distribution during priming, altered hepatic and renal clearance, altered serum drug concentration, also because of alteration in plasma protein, the two main plasma proteins, albumin and alpha-1 acid glycoprotein, leading to altered half-life of the drugs. Right. So summarizing everything in ECMO-related factors, which is causing a lot of effects on drug disposition, is the pump, the tubing, the oxygenator, the heat exchanger, the pump prime, which is going to transiently increase your circulating blood volume and the protein content and the circuit pH. Then the patient-related factors like renal hepatic dysfunction, inflammation, which is going to increase your alpha-1 acid glycoprotein and decrease your albumin, and cerebral perfusion alteration. So these are all ECMO-related factors which are going to affect your drug disposition. So now if you come to the drugs, so we spoke about two types of drugs, the hydrophilic drugs and the lipophilic drugs. In case of hydrophilic drugs, the volume of distribution is low. So when ECMO starts and there is priming and there is an increase in volume of distribution, the concentration of the hydrophilic drugs decreases, as a result of which there can be therapeutic failure, which we need to keep in mind. Also, the primary mode of clearance of hydrophilic drugs is renal, and the primary mode of clearance of these lipophilic drugs is hepatic. And the potential effect of critical illness on PK of these drugs is there is increased in volume of distribution of hydrophilic drugs. And if you see the effect of ECMO, there'll be increase in volume of distribution. And lipophilic drugs, there'll be no change in volume of distribution because of critical illness. And there'll be increase in volume of distribution because of ECMO. So if you see the sedatives and the opioids which we are talking about, so these are the main sedatives and opioids which we use in daily life, and this is a beautiful diagram to show the lipophilicity and the protein binding of these drugs. So as you can see, the fentanyl has the highest lipophilicity, and the protein binding capacity of propofol is highest. And coming down, it's fentanyl, midazolam, propofol, lorazepam, ketamine, dexmedetomidine, hydromorphine, and morphine. And similarly, in protein binding, propofol, midazolam, dexmedetomidine, lorazepam, fentanyl, morphine, ketamine, and hydromorphine. So we need to keep these things in mind before starting, these drugs, and how the pharmacokinetics of these drugs is going to be affected by ECMO and critical illness. So, so coming to the pharmacokinetics again, what I showed in the graph, I'm going to show in a table form. So fentanyl having the highest protein binding and quite a large volume of distribution, what it was noticed by in some studies, especially Shekhar K et al. In 2012, is that more than 70% of fentanyl is actually lost in the first hour of starting ECMO itself. So we need to be very careful about that. And 67 to 97% of losses in 24 hours. And similarly, propofol, these are the two drugs we need to be very careful about. The protein binding is 95 to 99%, and the volume of distribution is really, really high. So you see losses of around 70% in 30 minutes and 89% in 5 hours and 100% in 24 hours. So as I said, so the PVC tubings, the oxidation, all this is also important. And also the this have been demonstrated by the various studies like Shekhar et al. In 2012 and Harthan et al. In pediatric pharmacology in 2014. So the pharmacokinetic characteristic of all these analgesics and sedatives have been observed in these various studies. So to summarize about these drugs, about the lipophilicity, so please remember each and every point here is very important. That's why I have created these slides to summarize my point. So drugs which are more lipophilic are going to be sequestered in the circuit, right? In a study conducted by Shekhar et al., they demonstrated that significant reduction of the drug levels requiring high dose requirement. This we need to keep in mind. And they demonstrated the loss of fentanyl from the circuit was higher, 97%, compared to morphine, which was 0%, and midazolam, which was 87%. So the summary of this slide is the more lipophilic your drug is, the more prone it will be to be sequestered by the circuit, right? Next slide. Protein binding. The more protein bound the drug is, the more likely it is to be sequestered by the circuit. So the two factors which are most important to decide the sequestration by the ECMO circuit is lipophilicity and protein binding. Very important for your Viva also in your DNB exam. So please remember, these two are the most important points. So need for a higher initial loading dose with higher daily dosing regimen to reach the saturation of the receptors, as the unbound drug is the more pharmacological active portion of the drug. That's obvious, isn't it? So what type of drugs are going to come here which are going to have high lipophilicity and high protein binding? One is fentanyl, one is midazolam, and propofol. So please remember these factors before deciding the dosing of your drugs. So lipophilicity and protein binding is going to decide the drug sequestration in the circuit. Next, coming to the volume of distribution and drug dilution. More the volume of distribution, more the drug dilution. The drugs need to be administered in high bolus doses and maintenance doses, isn't it? So volume of distribution is affected by protein binding and frequent loss of albumin in the circuit, or SIRS or third spacing or whatever. Albumin is going to be low. So volume of distribution is being decided by these factors, mainly the protein binding and the albumin levels. And generally it is more important in neonates and pediatrics, but in adults also we need to keep this in mind. Next, circuit component and priming solutions. Now, polyvinyl chloride in the circuit is going to actively bind to your lipophilic substances, and it's a good source of binding drugs. It releases them later when the concentration changes. The drugs binds to the alkyl groups of the drugs of the polymer in the PVC tubing. Length of the circuit. More the length of the circuit, more chances of sequestration. Roller pump versus centrifugal pump. Now, some studies show that roller pump causes lesser sequestration. Centrifugal pump roller pump causes more sequestration versus centrifugal pump. But some studies say that it's equal almost. Priming solution. No actual studies have been actually shown any significant change in the drug characteristics based on the type of the priming solution. only that what we have discussed is that when you start priming the circuit, you're going to increase the volume of distribution and cause hemodilution in the patient. So you need to be aware of that. Now, what does the guideline say? So let's see. Routine assessment of pain, agitation, and delirium is extremely important in your ICU patients. Pain should be treated before sedation. Target light sedation versus deep sedation. Propofol or dexmedetomidine is preferred over benzodiazepines for sedation, and perform rehabilitation, mobilization, daily sedation interruption. So these are the key guideline concepts which you need to remember when you treat your patients on ECMO and consider analgesia and sedation. What does SCCM guidelines say? Depth and quality of sedation should be routinely assessed in all ICU patients, like in a regular ICU patients. The RAS and the SAS are the two most common scoring and the most valuable scoring systems which we have used for assessment of patients in ICU. Use objective brain function measurements in adjuvant to sedation in patients receiving neuromuscular blockage. EEG monitoring to see non-convulsive status epilepticus activities in all high-risk patients. Target lightest sedation possible. Sedation protocols and ICU checklists must be in place, and better use non-benzodiazepine agents as compared to benzodiazepine agents. Now, this was a study which was performed in and published in Journal of Critical Care in 2017. It was performed in Brigham and Women's Hospital, which is a tertiary care hospital. And what they did is they evaluated the use of sedative, analgesic, and neuromuscular blockage in patients in ECMO. It was a 2-year prospective observational study for an adult ECMO unit in patients who were on ECMO for more than 48 hours. And there were 32 patients included, 15 of which received VA ECMO and 17 of which received VB ECMO. And what they saw is that patient actually required relatively lower doses of sedative and analgesic while at a light level of sedation on average. And they rarely require neuromuscular blockage. And the hypothesis that the patient who are on ECMO are going to require highly sedative doses of analgesics and sedatives should be further investigated. So this was actually found by Degrado and published in Journal of Critical Care in 2017. It's a nice study. If you have time, please go through it. Now, what are the scoring systems which are normally using? I'm not going to go into the depth of this. You have been using this forever. The Richmond Agitation Sedation Score. You know about this. It's -5 to +4, -5 being unarousable and +4 being combative. So we always say that we target a sedation of RAS of -1 to -2 for a patient to be comfortable and in light sedation in ECMO. Similarly, we have a sedation agitation scale also. So 1 being unarousable to 7 being dangerously agitated. So again, we actually target somewhere 3 to 4 here, so that the patient is calm, cooperative, and lightly sedated. So these are the scoring systems which you need to use in your ICU, and the scales which you need to use in ICU to titrate is your sedation to tailor made according to your patient, because you can't use the same sedation level for all your patients. So you need to titrate it on the basis of these scales. So then Ramsay sedation score also you guys are aware of, 1 being awake, anxious, agitated, or restless, and 6 being asleep and no response. So here also we actually try to target somewhere around 3 to 4, where the patient will be comfortable and lightly sedated on ECMO. So please remember to use these sedation scales to titrate your sedation, because each and every sedation has to be tailor-made according to your patient. So what we need to keep in mind while choosing a pharmacological agent: an ideal agent should have following properties. It should be a sedative and analgesic. It should be anxiolytic. It should be an anticonvulsant. It should have minimum CVS and respiratory side effect. It should have a rapid onset and offset of action. No accumulation in case of hepatic and renal dysfunction. It should have inactive metabolites so that they don't linger on in your body forever. And it should have lesser interactions with other drugs. Now remember, this is an ideal agent. It's difficult to actually fit into all these characteristics, but we should keep this in mind and before starting your patient on any sedation and anxiolytic and analgesic in ECMO. So, let me talk about what our protocol of sedation and analgesia of ECMO were. So, some key points. Sedation and analgesia requirement may be higher in ECMO patient, especially only in early run. And then you need to reduce the doses when the patient is on ECMO. Accept multiple agents initially to make it more effective. Same principle as all ICU patients. Recommend daily sedation break and minimal dosage to maintain safety and clinical stability. Very, very important. Do not forget your ECMO patient is first an ICU patient, and like an ICU patient, you give daily sedation break. Please remember giving daily sedation break and minimal dosages and maintain a safety and clinical stable profile. Consider non-benzodiazepines compared to benzodiazepines. Aim to lighten sedation, wake early, and even extubate. You can give it a try. And to summarize again what ECMO does to your drugs, it increases your volume of distribution, decreases your clearance by adsorption, systemic inflammation, and hemodilution. So some protocol which we followed is initial sedation. We did use midazolam infusion for sedation. If the blood pressure is stable, then you add opioid, fentanyl, morphine, depending on your institutional protocol. Then may require neuromuscular blockage, SOS, atracurium. Subsequent sedation with propofol, analgesia with alfentanil or remifentanil. Consider haloperidol if the patient is agitated or delirious, and you can add enteral clonidine if the patient is agitated or delirious, which we sometimes did. And also difficult agitation requiring ongoing sedation, did dexmedetomidine infusion. Adding it to the other agents sometimes helped. So this is just summarizing one of the protocols which I came across. Now, just ending my talk. So at ECMO initiation, use continuous infusion. The requirement is high because of the priming solutions. The two most important factors which you need to consider is the lipophilicity of the drug and the protein binding of the drug, which is going to affect the pharmacokinetics in ECMO. Set daily sedation goals and consider daily interruption of sedation. And after ECMO decannulation, reevaluate the doses of analgesics and sedative. You need not, give such high doses, and monitor for delirium and signs of withdrawal. Thank you.
Thank you, ma'am, for the wonderfully detailed talk on sedation and analgesia during ECMO and the complex factors affecting the pharmacokinetics. If there are no questions, we can continue to Dr. Pranay's talk on ventilation. Dr. Pranay?
Yeah, I'm ready.
Sir, yes, sir. Please continue.
Yeah, I think I was here.
Yes, sir.
So what is definite we need to do is prevent the lung injuries in terms of limiting the alveolar strain, limiting atelectative trauma, limiting reabsorption, and limiting the over distension. And for that, what we need to do is we need to have a tidal of less than 4, pressure 20 to 25, peak pressures, maintain high PEEP of more than 10, decrease ventilator FR2, and to monitor the transpulmonary pressures. And so what we definitely need to do is restrict the peak pressure 20-25. That is all the studies have said. And the PEEP around 10 if there is no barotrauma. So PEEP should be 10 or more than 10 if there is no barotrauma. That is a definite thing we need to do, and decrease the FR2 as low as possible. And what we have been told not to do is not to exceed the peak pressures of more than 25. So what we usually do is we go for rest ventilator settings with the pressure control mode, respirator after 8 to 10 for first 24 hours, then peak pressure of less than 25, 26, peak of 12 to 14 in first 58 hours, and then 10, and FR2 we try to reduce to 21 to 30. For a VA ECMO, usually prefer no ventilation. If the patient is not on a ventilator, we don't want to intubate the patient, and if the patient is already on ventilator, we try to extubate as fast as possible. We go by lung protective strategy. Again, PEEP may impair the venous return, so you have to balance the pressures and the pulmonary edema part and decide about the PEEP. Over distension can increase the RV afterload, so you have to take care of that. if the patient goes in a left heart stasis or a left heart distension, then the pulmonary edema, and then in that case, PEEP will be helpful to you. You might have to keep PEEP to little on higher side up to 60 also, because always remember that your heart gets the blood supply from the native circulation, and that's the reason you might have to keep the FR2 high if the patient lung is not very good. So VECMO again, PCV mode, pressure control mode, respiratory rate 12 to 16, we have some liberty. Peak pressures around 24, PEEP of 10, and FR 30 to 40. Sometimes we go up to 60. Now, I'll just keep this case, I'll just go fast to the case discussion. There's a young female of 55 years. She was taken for dysfunction. She had dysfunction uterine bleeding. She was taken for laparoscopic hysterectomy, and after pre-operative fitness, she was being given started the surgery laparoscopy with general anesthesia, and she developed non-cardiogenic pulmonary edema, and she was unable to ventilate. She has gone into shock, and she is required high dose of inotropes. She had even cardiac arrest. She was unresponsive, and pupils were dilated. Sedation was stopped. An ejection fraction after doing after episode was around 40%. And this was an X-ray, and ABG was showing the pH of 6.9 and PCO of 122 and PO2 of only 38. Now this female was being considered for VV Ecmo. She was put on VV Ecmo after discussing with the family about the pros and cons and even the possibility of neurological no recovery. And then she gradually started improving after putting her on ECMO. She started passing good urine output. And this was the X-ray after putting her on ECMO. And she was conscious, and these are the X-ray pre-ECMO, post-ECMO, and day 3 of ECMO. And day 4 of ECMO, we have decided to extubate her, and extubation was done basically just to prevent the ventilator-associated complications, nosocomial infection. We can keep the patient awake, early mobilization is possible, and for better physiotherapy and use of BiPAP that you can use for to improve the patient's lung condition. And this patient was remained ECMO for around 20-22 days, and then she recovered completely and she was weaned off from the ECMO. So usually we practice extubation practice in a cardiac ECMO, definitely. In a chronic lung disease, mild to moderate disease, and chronic lung disease, end-stage disease, which is awaiting for the transplant, we always try to extubate these patients. Acute respiratory failure, if patient is not tachypneic and patient tolerates, then we extubate. So these are the patients we usually extubate. So this is the same patient which I was talking about. She was extubated, then she was given a feeding and everything. Another some situation is like pneumothorax, like you might see X-ray like this pneumothorax, and you might see continuous bubbling. Now in this case, we have to change our strategy of putting the ventilator strategy. Here in the case of Ehrlich syndrome, we try to restrict the peak pressures to less than 20, and PEEP we titrate from 0 to 6. So what we do, usually we keep the PEEP of 0, see how is the bubbling, and we can gradually increase the PEEP by 1 and see whether the bubbling is increasing. So we see how much the bubbling a patient can tolerate the PEEP. Now keeping the 0 PEEP will have because the other lung is also diseased. So if you only leak from one side, if you keep the PEEP 0, the other lung will not get inflamed, doesn't remain open. So again, the attenuated will increase. So you have to always titrate the PEEP between 0 to 6. Keep patient preferably on pressure support so that the spontaneous breathing will help them. And in rare situation also, we might have to think about doing differential ventilation. So we have to ventilate both the lungs separately. You might get some scenario like this, pulmonary hemorrhages. And in that case, usually you require to give some PEEP effect. So you might have to use higher PEEP. Many times we use APRV mode with a P high of 20 and P low of 2. And we just keep very low time for escalation. So T low is around only 0.6 to 0.8 seconds only, FR to 21 to 30. So we just keep the lungs packed with the APRV mode. In case of north-south syndrome, as we discussed, because there is a hypoxia of upper half of the body, because the lung has to, it is basically the upper half of the body depends on the lungs for the ventilation. So you have to keep on higher side of ventilation settings. You have to accept higher side ventilation setting. And if nothing helps, then in that case, you might have to think about APRV mode or HFOV, or if nothing helps, then go for VAV ECMO. Now, this is the one which we always face most of the times problems when the patient is on spontaneous mode. We want to keep them. So, but then they become tachypneic. So we usually accept respiratory rate around 30 to 34, and we see there is a no distress. Only the respiratory rate is high. That's fine. If there is a distress, then we don't accept it. If the respiratory rate goes above 30, then what we usually do is we increase the sweep gas and try to get the PCO2 down to 30. So by adjusting the sweep gas, if you get the CO2 down to 30, the respiratory drive decreases and patient becomes more, the breathing becomes more comfortable. So what is important is the lung rest is most important. The lung recovery is the priority. So you have to wait and watch. Use ultra protective ventilation. Recruitment strategy only when the lungs are ready. You have to give a chance to lung to heal and reopen gently. Don't try to push it. So what usually we do in our center is in VA ECMO, at the time of initiation ECMO, in VA ECMO, if there is no patient on ventilation, we don't ventilate the patient. If the patient is on pulmonary edema, we ventilate them with a high PEEP. And once the patient improves, we take off the ventilator. In VV ECMO, first 48 hours, we follow ELSO protocols. We get the PEEP down gradually. So if the patient is on 16 of PEEP, we keep the PEEP around 14, 15 and on first 48 hours, and then we get the PEEP down gradually. Respiratory settings, and we try to prone the patient if there's no contraindication. So if there's no evidence of barotrauma, then if there's evidence of barotrauma, then we get the PEEP pressures down to less than 20 and PEEP we titrate as I told you. After initiation and stabilization, a few days to few weeks, we in VA ECMO we don't even ventilate, extubate them unless lung is an issue. In VV ECMO, we reduce the sedation, try to make them awake, go by a spontaneous mode of ventilation, either a pressure support PEEP or APRB or bilevel mode. We accept RR up to 30, get the CO2 down by increasing the sweep gas. If patient is tolerating well and stable, then we consider them extubation. If patient is not tolerating, we go back on control mode and try to evaluate the cause and treat the cause. Thank you. Any questions, I'll be happy to answer.
Thank you, sir. We have one question. How do you mobilize a patient on ECMO with femoral cannula in situ?
See, femoral cannula is again not a contraindication. What we do is, it's not that even we have mobilized patient with a VA ECMO with femoral artery cannula also. But it is a gradual process. So what we do usually is, we on day one, we try to make them move the legs with the knee flexion and hip flexion. And then we see there's no hematoma or something. Gradually then make them proper position for 45 degrees, 60 degrees, 90 degrees, and we see whether they tolerate, whether there's no issue with the flow and there's no hematoma or bleeding from around the cannula side. Then we try to make them sit with the bedside. So we keep them leg hanging on the bedside and sit them, and then we take them on wheelchair. Next step is, once they are on wheelchair and there's no issues, then after 1 or 2 days we make them stand and start them walking. So that's a gradual process how the patient tolerates. We go gradually and see, and then we decide. It's not that all the patients we can able to mobilize them. Only few patients with once the acute phase is covered, then only we are able to mobilize. If the patient is in acute phase, then it becomes difficult to make them mobile.
Thank you, sir. If there are no more questions, we can proceed to the next lecture. Next lecture we have by Dr. Poonam Malhotra, who's Professor, Department of Cardiac Anesthesiology, All India Institute, Medical Sciences, New Delhi. Ma'am will be speaking on blood transfusions, when and what. Ma'am, if you can start, please.
Can you see my slide? I'm just sharing.
Not yet, ma'am.
Okay.
Ma'am, I think Dr. Vinay is also here. He can start with his talk if possible,
Yes,
and we can
please.
sort this out.
Go ahead. I'll just sort it out.
Dr. Vinay, are you there?
हाँ हनीत मैं जस्ट 1 मिनट लूंगा वो प्रेजेंटेशन जस्ट
मेरे को 3 दिन पहले दिख रहा था.
So we'll start with Dr. Vinay Singhal. He's Director Critical Care, MM Medical College, Ambala. So he'll be speaking upon procedures during ECMO and challenges.
presentation with you.
Okay, sir. Okay.
Yes, yeah, now just open system preferences. Actually, it's a I shared my presentation with you. Actually, it's I had already combined the presentation and I had prepared it for tomorrow, surgical intervention. So I'll be taking it today as a whole, and I shared WhatsApp you this presentation. Please share if you can.
Yes, sir. Can you see, sir?
Yeah. Yes, I can see.
Yeah, Vinay, we can see your slides.
Yes. So, good evening and sorry for a delay. Actually, I was prepared that I'll be presenting tomorrow only. So, maybe in bit I had to hurry certain things, but I'd like to yours speak about. Actually, I was allotted two topics, and I mixed them both of them. One is the challenges during the procedures when we do during ECMO, and then surgical interventions during ECMO. It means procedures we do during ECMO. So, if we look at the procedures, we look at these. Am I audible, Harneet?
Yes, sir, you're audible.
Yes, sure. So, can you forward the slip? Actually, you had to do. So we can see that yes, things have changed in past so many years, almost 50 years, more than 50 years. So we had seen that there used to be too much of chaos during when this ECMO was started in 1971, and nowadays we have a very handy equipment which doesn't require that much of mix up of lines and all, and handling becomes very easy nowadays, and things are far easier if we compare in this development of ECMO in last 50 years or so. But I can share your my experience around it was around 2010 when we used to talk that yes, how can we think of ECMO, and it's so costly and all these things, and just after 5-6 years after that we were doing our own ECMO, and we are seeing around in our own city. Dr. Vivek has started in Ludhiana, and then we followed him up. So actually, he's the teacher for us in Ludhiana for this. So things are easier, but still lot many things are there. Please, next slide, please. Anit, next slide. Yes. So, with the evolution of ECMO circuit and better understanding of its physiology and management techniques over the last 50 years, now more complex procedures and operations are being performed safely on patients on ECMO support. So, we are seeing patients are being taken on ECMO. Next, please. And next slide, please. But nevertheless, your last slide, please. Yeah. Nevertheless, surgical and interventional procedures on the patients on ECMO support carry the risk of life-threatening bleed on one hand, and if we don't manage it properly, and again, if we don't manage it properly, it can lead to increased risk of thrombosis on the other way around, and which cannot be underestimated. So both things can happen. Either your patients can bleed, or these are the one of the complications, and which we look straight away. And beyond this, there are many more complications we see during ECMO. And what happens? Next slide, please. So this was one of the studies was published in 2019, and it was a single institutional study, retrospective study done from 2012 to 2015. And here outcomes were compared between the patients who underwent general surgical procedures with those who did not. Next, please. And what they found is that, last slide, please. Sorry. Duration of extracorporeal membrane oxygenation was longer for the patients requiring your general surgical procedure. So patients who required these procedures on ECMO, they have to stay for a longer time on ECMO support. And although these procedures are relative, they are safer and they are possible in adult extracorporeal membrane oxygen patients. So it was possible to do the procedures, but definitely patients were having, they have to stay on ECMO for a longer time. Next slide, please. So they again this studies reiterates that patients who underwent general surgical procedure, they have to spend a longer time on ECMO in the hospital. Approximately 36% of all adult patients in a study required at least one general surgical procedure. So patients, approximately more than 1/3 of patients required some or other procedures, and most common procedure performed was percutaneous tracheostomy. Second and third most common procedures which were performed were the open tracheostomy and surgical percutaneous gastrostomy, or exploratory or decompressive laparotomy. Next slide, please. These patients also we had seen they required more number of blood, and they had seen that yes, more transfusions needed was associated with this almost similar SOFA score in these patients, and the blood required in most commonly during the percutaneous or open tracheostomy in approximately 85% of patients, percutaneous or open gastrostomy in approximately 81%, and laparotomies, decompressive or exploratory laparotomies required almost 100% of patients required your this thing blood transfusion. And you can see the survival is almost they have approximately 20 patients have survived here. That is approximately 57% of patients have survived in patients who received transfusion, and 100% of patients survived which received no transfusion. So all these things are related with the poor survival rates also. So more general surgical procedures means more need of blood transfusion. And again, despite the initial SOFA score of the survivors are almost same, but again your mortality was higher in patients who received in the group. Next slide, please. In the group who required more transfusion. So we have to understand that yes, do we need a procedure? Do we need to plan a procedure on ECMO? So because there is a problem on ECMO, and we need to plan. We may need to plan a procedure. So why do we need need to plan a procedure on ECMO? Because you have to think that yes, your procedure is invasive or non-invasive. Is it a bedside procedure or procedure for you have to transport the patient to some other unit or maybe operation theater, maybe for a radiological procedures, or just for the scan or CT scan. MRI cannot be done in these patients who are on ECMO because of the many reasons, but we have to see that yes, your patients who are requiring a non-invasive and bedside procedure or invasive, or these patients require transport. So things will be worse if your patients need an invasive procedures or the patients who needs transport. Next slide, please. So we need to answer certain questions and decide as a team. Decide as a team means we have to look for the team means your people who are treating this patient, and that should include a perfusionist, your anesthesiologist, your ECMO physician, and your whosoever is there, even the surgical team need to answer certain questions and decide. Next slide, please. So why if this procedure is necessary? So we have to answer this pertinent questions. Why do we want this procedure if this procedure is necessary? If your patient can wait and procedure can be done after 5 days or 10 days, or after your patient is weaned off from ECMO, then we should wait. But again, if this patient is an emergency or partial emergency, your patient may need to be operated immediately. So we have to answer first that why if this procedure is next, please, and when, and again why, and then we have to answer when. If this procedure is an emergency procedure, then definitely if patient is having pneumothorax, tension pneumothorax, or GI bleed, these patients require immediate attention. So here there is no question that yes, we'll delay the procedure or we'll do it afterwards. It's a life-threatening emergency, and you need to plan a procedure according to the need of the patient. So why and when. Next slide. Where again, bedside or need transport. Bedside, it becomes far easier for everyone. Need not to take all the patient along with all these tubings and ECMO console, everything. You need to transport this patient along with everything. And if your patient can be operated, or this procedure can be done on a bedside, it's a big relief for everyone whosoever is managing this patient on ECMO. And again, if patient need transport, we'll discuss in next few slides. Next. And who is going to perform the procedure? Who is, again, there is no chance of taking risk. Most experienced operator should be performing the procedure. So there is no way that yes, my junior or my third in the row or fourth in the line will do the procedure. No, most experienced operator should be performing the procedure. Next. Then how it should be done. So how then comes, once we answer all those questions, then we have to come for the how. That how means that we have to create the optimal condition for the procedure by altering the anticoagulation. If we need to alter the anticoagulation levels, we have to alter the anticoagulation. If it's a non-invasive procedure, then we can need not to change the anticoagulation level. So most commonly used anticoagulant is still the heparin. So we need to either hold the heparin for some time or change the rate of infusion, or we may need to add the clotting factors and platelets. Sometimes your patient may be having deficient coagulation. So here you need to add some clotting factors, or arrange some plasma, FFPs, your plasma, platelets, blood, and other blood products. So, and administer antifibrinolytic. Again, if it is required, then again we need to be prepared ourselves. We have to prepare ourselves for antifibrinolytic. Next slide, please. So again, please, next slide, please. I think this was mixed up, had happened. Next. So yes, what are the procedures we have on ECMO? There could be divided as a diagnostic procedures, diagnostic and therapeutic procedures, and procedures related to the ECMO circuit. Diagnostic procedures are usually non-invasive procedures like echocardiography, transesophageal echocardiography, or transthoracic echocardiography. These can be done bedside, non-invasive, no need to change your anticoagulation, and can be done easily. And again, neuromonitoring and like CT scan or MRI scan. MRI scan we can't do here. CT scan we can definitely do, and we need to transport most of the time. In our setup, in our country, most of the patients need transport to the CT console, and if certain centers still having some bedside CT scans. So most of the centers we still transport these patients for the CT scan. Transcranial Doppler, again non-invasive procedures, has to be done on the bedside. Optic nerve sheath diameter monitoring, cerebral oximetry monitoring, and point of care ultrasound for various reasons. These can be done on the bedside. And patient need not to be transported out of the ICU or out of the bed. So again, there will be some procedures that can be done bedside, but they are partially invasive, like bronchoscopy, minimally invasive, partially invasive, and gastrointestinal endoscopy. And these two procedures can be therapeutic, also diagnostic and therapeutic both. And cardiac catheterization, a very important procedure. Sometimes we need to take the patient to the cath lab and do the angiography, and they may require stent placement. Many times patients are on ECMO because of some certain cardiac issues. Then comes the totally therapeutic indications like enterotracheal intubation need to be done bedside. Not much change in your anticoagulation is needed. Tracheostomy, again, and one of the most common procedures done on the ECMO, and definitely need some holding of anticoagulation. Chest drains placement for tension pneumothorax, vascular access, central lines, dialysis catheter insertion, your repositioning of not exactly reinsertion, but again positioning of vascular access may require, or handling of those catheters may require. Renal replacement therapy, again, it's a procedure that can be, you need an IV access, vascular access, and general surgical and thoracic and neurosurgical procedures. Again, from moderate to very high severity of procedures may be there. We may need to do some craniotomy and all in certain patients who are having bleed. And ECMO, we need to change the circuit, pump, or oxygenator because of malfunction of any of these components. Next slide, please. Next slide, please. Yes. So if we come to the transport, again, it's a procedure. It's a kind of procedure on a patient on ECMO because it has a potential risk of decannulation, pulling out of lines, and it has a definitive risk. And we have to explain to the relatives, and we need to have a checklist of necessary equipment and personnel. So because we need to transfer out the patient from the bed to the stretcher, then stretcher to that particular OT table or console CT table, or then shift the patient back to the stretcher and to the bed. So we need to have a number of personal requirements and ECMO circuits. Perfusionist is definitely required. We cannot do all these procedures or transport without the presence of a perfusionist and who can handle the circuit very well. A hand crank, power cord, and an oxygen cylinder definitely are needed during the transport. Next slide, please. And before precautions, what precautions we take during and before the procedures, standard precautions has to be taken, like we take for all the procedures: consent pre-procedural preparation and briefing of the team, presence of perfused stage mask, level of anticoagulation, dose of heparin. If infusion need to be adjusted as per the need of procedures. Major surgical procedures may require the use of recombinant factor 7A or antifibrinolytics. Next slide, please. So risk of circuit thrombosis is reduced at higher flow rates, and thus this practice is often undertaken if anticoagulation is held or antifibrinolytics are administered. So we have to, the moment we administer your decrease the anticoagulation, or we add some blood products like plasma and all, we have to see that our flow rate should be the maximum, because these higher flow rates have some because stasis is one of the factors which is needed to increases if we look at the workout triad. So stasis is one of the factors which induces the thrombosis. Next slide, please. So again, we have to look at the anticoagulation monitoring, and it has to be taken as a separate. I think there is an anticoagulation monitoring we had already talked, but again, hemorrhagic complications produce significant morbidity and mortality among the ECLS patients, and their prevention requires correcting coagulopathy and thrombocytopenia, careful titration of anticoagulation therapy, and repair of the surgical source of your surgical source of bleeding. Next slide, please. So blood product and factor replacement when to be done, and platelets transfusion, we have to maintain the counts more than 80,000 to 1 lakh, and INR should be maintained less than 2. Fibrinogen cryoprecipitate should be used to maintain the fibrinogen level more than 100 milligram per deciliter, or more than 150 milligram per deciliter if bleeding is or prior to the major surgical intervention. Hematocrit, maintain the hematocrit more than 30%. Consider the higher goals for neonates and children with cyanotic congenital heart disease, or lower goals for the stable adult patients. Antithrombin more than 50%, and consider antithrombin replacement if on maximum dose of unfractionated heparin and unable to obtain the therapeutic antifactor 10 assay. Next slide, please. So certain threshold your for transfusions is Paxel. If your hemoglobin is around 7 to 7.5 grams per deciliter percent, and platelets 50,000, and no routine transfusion threshold for FFP. But again, we have to look at the factors, patient's condition, and then we have to transfuse the FFP. Next slide, please. So antifibrinolytic use to control the post-operative bleeding, and epsilon aminocaproic acid and tranexamic acid is used in many centers to prevent the hemorrhagic complications in patients having surgical procedures. And next please. Uses are not universal, and next. So we have to use this tag, and this is important if we, and that can help us in monitoring and initiation of the tranexamic acid or antifibrinolytics in our patients. And if your tag is showing a certain this curve, especially this A curve, so then you can definitely start with, then only it can be beneficial. Otherwise, blindly giving tranexamic acid may or may not help the patient. Next slide, please. Next, please. We had already discussed this. So next, role of endoscopy. And again, endoscopy is one of the common procedures, and it is life-saving, and because causes of bleeding in Ecmo are multifactorial and includes heparin administration, coagulopathy, thrombocytopenia, platelet dysfunction, acquired von Willebrand syndrome, and hyperfibrinolysis. Next. So we have to see the GI bleeding has been reported in approximately 4.2% of patients with cardiac support, and in approximately 5.2% patients with the respiratory support. Next, please. So endoscopy has a high clinical success rate in GI bleeding control with minimally invasive. Despite the absence of mortality due to GI bleeding, the ECMO course was significantly longer in the GI bleeding. So we see that, yes, whenever these patients require some procedures and especially bleeding things are there, these patients higher blood, we had already seen in those that paper that yes, these patients have a longer stay on the ECMO. Next. And advanced endoscopy therapy during the venous extracorporeal membrane oxygenation may contribute to reducing the negative effect on mortality for GI bleeding episode. Next, please. So GI bleeding is easy to handle nowadays with because of its minimally invasive approach with the endoscopy. Tracheostomy is one of the most common surgical procedures on ECMO. And percutaneous tracheostomy is definitely safe and usually performed under bronchoscopy. Ultrasound may avoid minor vascular and thyroid injuries. Transient interruption in heparin infusion prevents bleeding episodes. Next, please. So again, this is the National Inpatient Sample Database was examined for patients supported with ECMO from 2007 to 10. Next, please. So they had seen that general surgical procedure were maximum in these patients, approximately 40%, followed by the extremity or vascular surgeries. Thoracic procedures approximately 23%, and neurosurgical procedures are around 2.9%, then other procedures. Next, please. So definitely there is a increased length of stay. And next, please. Next slide, please. The high risk of infection and your higher antibiotic use, longer stay, all these things are again seen in this trial, which was published in 2015 also. And patients supported with ECMO is feasible and does not result in increase, not cardiac surgical procedures. They doesn't increase the mortality. However, it does result in increased morbidity, longer hospital stay, and increased cost. Next slide, please. Next, please. Cardiac catheterization. Yes, we had already discussed. Then comes the eCPR. We are going to discuss it again on the workshop day, and it's had a short-term and long-term survival benefit over the conventional CPR in patients with in-hospital cardiac arrest of cardiac origin. Definitely, it should be a cardiac origin if it is of cardiac origin. Next slide, please. So coming to my concluding slide, with the development in ECMO circuits and a better understanding of physiology, we are managing more and more complex cases. We had already seen, and everybody is seeing that yes, in last 50 years we had come across many more complex cases nowadays. These patients require more intense monitoring and may need to undergo many elective or emergency procedures, but we need to always answer certain questions: why, when, where, who, and how. Whenever we think of a procedure's level of anticoagulation and ECMO flows need to be adjusted as per need of the procedure. Avoid any air entering into circulation either through the ECMO circuit or from the surgical site or cardiac catheterization sites, and that is very important whenever we do a procedure, because we have to avoid any complications that arise from our hands. Next. Thank you very much. Thank you.
Thank you, sir, for the wonderful lecture. We have a question in chat that can you do MRI if a patient is on ECMO?
I don't think so. As far as I know, because of your maybe one is all these wires are there. Your MRI, your console is not MR compatible. ECMO console is not MR compatible. So I don't think as of in present scenario we can do MRI on our ECMO. Dr. Pranay is there, sir. Sir can answer if we do have.
MRI cannot be done because basically it's a ECMO is a magnetic field itself. So it works on the magnetic revolution is basically on magnetic field. So MRI is not possible on ECMO.
Okay, thank you, sir.
While I'm sharing my slides, there is a paper, very recently, Dr. Pranay, where they have done MRI. They say that an MRI can be done, and they have quoted that how they got it done. And they've said that MRI can be used for early diagnosis of cranial complications in patients on ECMO. This is from a neurosurgery journal. And they say that patients who have any cranial complications can, under all circumstances, and how they did it, they've described it as a case report. And it was also done in 2006, and then another report recently in 2023. But then I think it's a very difficult thing to do. I still can't share my content, and you can't. And there is some problem with the way, because it's opening on my thing, and if I do the screen,
WhatsApp me, I will WhatsApp to Harneet.
I have given it to Harneet. So if
Harneet, can you share from your side?
Ma'am, I don't have the permissions to open the file that you mailed. Can you give me permission that?
तो mail से ही करनी पड़ेगी. I'll just give it to you. I'll just give it. Because I don't know why. See, मेरा screen share हो रहा है आपके साथ. I can do it, but वो share वाला button नहीं आ रहा.
Ma'am, you have to not select the screen, but select the app, Microsoft PowerPoint. First screen or application, under that there is optimize automatically, and below that Microsoft PowerPoint.
उसमें Microsoft PowerPoint आता ही नहीं है.
Ma'am, have you opened your slides?
My slides are open. My slides are with me. See, when I do optimize text and images आ रहा है, उसके बाद आ रहा है application और एक तरफ आ रहा है screen. When I choose the screen, normally I should get share screen, no? वो share screen नहीं आ रहा.
Ma'am, just give me permission. I'll share the screen.
Okay.
Meanwhile, there's one question from the delegates. If person is not able to feed enterally, what TPN should we use? See, usually we avoid using lipid-based one. We just give them the essential amino acids and the dextrose. But with the PMP oxygenator, we can use even the lipid-based one. But definitely we try to avoid as far as possible, because there must be some, because silicone oxygenator and hollow fiber oxygenator has got a lot of issues with the lipid-based drugs and lipid-based enteral feeds. So we usually try to avoid that. If anybody has got any other questions, whatever the topics they have been discussed since morning, you can ask. I mean, by the time they sort out with the issue.
Sir, there were some questions in the chat regarding anticoagulation.
Yeah. Just read out. I'll help them out.
Yeah.
Okay.
So, excuse me, sir. So, what TPN should we give? What and nutrition should we give to the patient if we are not able to give even lipid-based parental nutrition to the patient, sir? And he's not accepting the enteral feed, sir.
As I told you, initially we just give them the albumin, the essential amino acids, and the dextrose, what we can give safely. But if the parent, if the enteral feed is getting prolonged for a long time, even the lipid base also we can use it. But we try to keep it as far as possible. We try to avoid it.
Okay, sir. Thank you.
Yes, Amit, can you tell me what are the questions on anticoagulation?
One second.
So there are certain questions on last presentation also. I think I had to logged out.
Can you see the screen? I have just
no. I've seen the screen earlier, but again now it's not. No. Yeah, no, it's good.
is it visible?
Yes.
Yeah, we can see the slide screen. You will just change it to PowerPoint mode.
One
Slideshow mode. Yeah, I think that's okay.
Dr. Poonam, you can start.
Okay. Okay, can we do it into a play screen mode, a bigger screen? Hello, can you hear me?
Yes, ma'am, I have maximized the screen.
Okay, thank you. Sorry for all these delays, but I hope this talk is worth all the delay that has been caused. And there are beautiful questions and very practical questions on anticoagulation. I hope Dr. Panay, and I'll also help him, can answer these at the end of this talk. Well, blood transfusions are Ecmo, when and what. So much has been happening. Next, please. Can we go to the next slide? Yeah, so from SWAC-ELSO 2018 to 2023, wishing Vivek all the best, and beginning today on a very positive scientific note. I'm sure this conference will be a grand success. We know that the initiation of Ecmo and CPB surgery brings about hemodilution. Many speakers earlier have spoken about it, but what it brings about is also an inflammatory response and a surge response. And also with it, a lot of thrombin generation. Next, please. When the thrombin is being generated, it is this centrifugal pump that brings about all the changes. Also, we know that oxygen has to be in a balancing act. Oxygen delivery and oxygen consumption both have to be balanced so that both bleeding and coagulation are balanced. But many studies as recently as 22 and 23 say that bleeding complications are seen in up to 30 to 60% of patients who are on Ecmo, and they receive whole blood transfusions while on Ecmo, and this occurs very frequently. We've been in an era of liberal transfusions during Ecmo. And there are no randomized controlled trials, however, for RBC transfusion thresholds on Ecmo. Dr. Lakshmi just beautifully told us that Dr. Tyagarajan has started, and Ravi Tyagarajan from UK earlier has been a pioneer on anticoagulation. And I'm sure this transfusion on Ecmo, his 5-year project, will bring about some randomized controlled decisions into finally a guideline into what should be the triggers. And this is what my talk, which exists today in the form of triggers, some invasive, some in non-invasive, and some for transfusion, and some not for transfusion, I'll be talking about. Next, please. Can we go to the next, please? Yeah. So risk of hemolysis increases. There is indications of RBC transfusion when we are priming the Ecmo circuit. This beautiful priming video, unfortunately, is not working because I've transferred the slide. Maintaining the oxygen capacity, that is very important, that the oxygenation has to be above 80-85%, even on ECMO, at least above 90-95 on a VA ECMO. So when you want to maintain the oxygen delivery, enhance the saturation, you will give blood. Also, treatment of bleeding complications in different formats, and hemolysis and circuit management, especially when there are thrombi, and some clots. Next, please. So when we are seeing these, we must see the effect of platelet transfusions on ECMO. Platelets are the universal backbone of bleeding. The platelet aggregation and brings about good platelet function. Along with it, the fibrin and the meshwork happens. So a good clot is formed. This good clot also has to lyse, and this lysis happens within 30 to 60 minutes. So platelet function is most important, and an adequate platelet more than 50,000. Someone has said, what do you do? I think one of the questions asked is when the platelet count is 50,000 or below. Well, you transfuse platelets, platelet concentrates if they're available. You have platelet concentrates available in India also now, but they are expensive. Or you give random platelets, or you give single donor platelets. Whatever the platelet you give, you get the count up to about 85,000 at all times. Bleeding happens, and if a bleeding is ongoing, we all know it is a morbid and mortality situation, and mortality due to bleeding is as high as 45%. Next, please. A lot of these studies coming in are talking on transfusion, but the culprit here is this centrifugal pump. The pump, which is better than a roller pump, has a high hemolysis index, and this high hemolysis index is dependent on the speed of the pump. So that's why the low flows, pulsatile ECMO flow is preferred over a higher flow, which is non-pulsatile. But at the same time, better centrifugal pumps are coming on in the future, and I'm sure this hemolysis and bleeding that we talk of, because of this ECMO circuitry going on probably in a prolonged manner, would bring about better changes. Next, please. When we talk about centrifugal pumps and we talk about blood product transfusions because of hemolysis and bleeding, then let us remember that hemodilution, as Dr. Mona Lisa also pointed out, hemolysis and coagulation disorders, not only are they very common, but also not only no randomized control trials and guidelines exist, but the only evidence comes from observational studies and small scattered case reports that my patient is bleeding, I did this. I gave vasopressin, I gave desmopressin, I gave Novo 7 factor 7. There's so many of such case reports, but these case reports are not the targets. Next, please. So therefore, we need to have guidelines, and these randomized control trials need to increase. Dalton et al. Reported that bleeding events to the tune of 70% on ECMO and thrombotic events to the tune of 38%. This is high, and when you have these high events, then the mortality also reported in this annals paper by Dalton in American Journal of Respiratory Care was as high as 45%, as reported previously, 44% by other authors. Next, please. So platelet transfusions also bring about enhanced mortality, but they should be catered to. There is a lot of variability that exists in blood product and procedure acceptance amongst even the Jehovah's Witnesses. These are patients who refuse to have blood. Now, in these, what do we use? Instead of whole blood, we use recombinant factors such as erythropoietin. We can, instead of red cells, we use albumin. Instead of white cells, we use clotting factors. Instead of platelets, we have colony stimulating factors. For fresh frozen plasma, we can give them cryoprecipitate, and for autologous pre-donation, we give hemoglobin-based oxygen carriers. Today, you have artificial blood available. You have fibrinogen and fibrin coming as concentrates. You have immunoglobulins as concentrates. You have interferons and interleukins, thrombin, prothrombin, Rh factors, as well as sealants. These fibrin sealants or glues, as they come in, are very good for stopping bleeding. And this is where ECMO should also move, because we know too much of whole blood is dangerous. Therefore, learning from the Jehovah's Witness, we could move on to this, that we use alternatives to packed whole blood cells or leukocyte depleted red blood cells, because RBC, even leukocyte depleted, are causing TRALI, are causing a lot of villi and ventilator-induced lung injury with transfusion-induced lung injury is hazardous even in rest ventilator settings. Next, please. So whenever we are doing all this, let's remember that ELSO registry report also said that the rate of complications of clot formation resulting in the circuit replacement is about 20%. It is not easy to replace a circuit, just as it's not easy to get an ECMO patient to get an MRI done. It is not easy to replace an oxygenator or even the circuit or while on ECMO. It has to be a deft, very swift process only in the hands of experts, and you may end up losing the patient during the circuit change. But circuit changes do happen due to bleeding problems. Therefore, transfusions are a must to avoid circuit changes in these bleeding patients. Next, please. When we are seeing all this, let's also remember that while we were doing platelets and platelet aggregation, good platelet aggregation is need of the hour. Next, we must, these are the platelets, also help in clot retraction. We have seen a risk of hemolysis. This is a duplicate site. But I must emphasize here that you must, on a patient who's bleeding, see the oxygenator with a torch test, see the increasing bilirubin, see the increasing urea and creatinine. Look out for plasma-free hemoglobin, something that we don't do in the Indian scenario, but the Western world does. They routinely do twice a day or thrice a day plasma-free hemoglobin, even in their with their ABGs or in their point of care tests. And this plasma-free hemoglobin, if it is rising more than 500, they say, or if you see a decreasing hemoglobin and a rise in the plasma-free hemoglobin, these are sure shot signs along with the change in color in the urine that your patient is bleeding. Next, please. So when you're seeing all this, you remember that today we are in that phase of learning where the cycle is post CPB or platelet dysfunction and fibrinolysis, and our intrinsic extrinsic meeting at the common pathway where 10 gets converted into 10A and 12 gets converted into 12A, and fibrin converted to fibrin is the common pathway. But at all these common pathways, the generation of thrombin, and this is what we don't want because thrombin is going to bring in SIRS. So this thrombin storm is what we are trying to prevent. And this thrombin storm prevention is going to activate the fibrinolytic pathway, and therefore fibrinogen on ECMO is seen to be less. Fibrinogen is the first factor, and the first factor of the blood products, fibrinogen, followed by prothrombin, followed by desmopressin. You have so many blood factors, which all of you have learned in your MBBS days, but remember it is factor 8 deficiency, factor 13 deficiency, and factor 1 deficiency, which is most common on prolonged duration of ECMO. And also remember that today we are in a phasic cycle of a common pathway. I don't want to go into the details, not this classic cascade of intrinsic, extrinsic, and common pathway. Next, please. So when we are doing these different things, we have problems of demand versus supply, financial consequences, hazards of transfusions, and therefore patients also don't want so much of transfusions. Every patient today is aware of the hazards of massive transfusion. Next, so we don't want to have so much of transfusion, so we must know what is the blood to be given. So liberal RBC transfusions in ECMO have been the norm, as I said earlier, but in the Indian scenario now, there is a move towards restrictive blood transfusion in most of the tertiary care centers because we know that all these problems of massive transfusion and liberal transfusion exist. Next, please. So while we are moving on to these, can I move on to the next 4-5 slides? You can skip the next 4-5 slides. I've spoken about it. So this is, no, can I go to the previous slide? Just the previous slide. The one before this. One more previous. Thank you. So while we are on ECMO, next one, please. We must discontinue the antiplatelet drugs. While we are on ECMO, we must know the utility of clinical history. If there's no history of bleeding, then it's good to do point of care tests. And these are recommendations which we gave for various, about 30 different case scenarios, including PPH, including sepsis, including ECMO, including cardiac surgery, Bental, aortic dissections, many such trauma patients, chest trauma patients, brain hemorrhage patients, while how to go about having these guidelines. And these recommendations in 2021 in JOACP journal by us, the whole group of at least 35 hematologists and intensivists from different parts of different centers of India came together for this ICMR project. And we decided that these are some of the best tests that should be done on point of care tests. Extem, intem, fiptem, and heptem should be done on a kaolin-based tag or a rotum, and a multiplate. These are the patients who should also be monitored with an ACT an APTT, and anti-10A with TEC platelet mapping. This TEC platelet mapping or total platelet mapping on aggregometry tells us the function of the patients when they have discontinued, or the residual effect of heparin, or the residual effect of any antithrombotic agent like dabigatran, zimalgatran, or antiplatelet agent like aspirin or clopid is still there in the patient. This is more so for the adult patient, not for the neonates, not for the child. But when patients are undergoing a high-risk PCI with Ecmo, we need to test the platelet function. So platelet function testing is becoming a norm in most cardiac Ecmos, and also very important to know that point of care testing, whether with sonoclot, rotem, or TEG, is here to stay. And I would like to go to my next slide. So we did these. Can you just punch them one after another, saying that whenever there is a protamine overdose, or heparin residual effect, or a DIC, or hypothermia, then ECMO will have altered blood tests, and we must do viscoelastic testing for these patients. Is the patient coagulopathic? Next, is the patient in consumptive coagulopathy? Is the patient hypovolemic? Next, please. Is there no volume in the patient? Also check whether we have preoperative transfusion risks more than 10%. We must cross-match our RBCs. We must detect, evaluate, and manage the anemia. We must have intraoperatively normothermia, coagulation management, point of care testing, and minimizing taking of blood samples as much as possible while the patient's surgery on ECMO is going on. This is what we follow, because we do a lot of integrated ECMO. We start the patient on ECMO, we come off on ECMO for 5 to 6 up to 12 to 24 hours, and the patient gets stabilized on ECMO rather than on a CPP machine. And this is how we are able to save so many of our patients. Next, please. While we are doing this, I would like to say post-operatively, you normalize, and we always use ECA or tranexamic acid in most of our patients to prevent this bleeding and hemolysis. Next, please. So minimize blood samples, optimize the cardiac output, and cardiac output and hemodynamic stability is very good. Remember unfractionated heparin during COVID, low molecular weight heparin. It served as a very good surrogate to heparin in the COVID era. Patients on low molecular weight heparin with anti-10A measurements could be titrated well on ECMO. And accumulation, low molecular weight heparin accumulates in the kidney, so renal clearance is a big hassle there. But bivalirudin, argatroban, and antiplatelet agents are on the horizon, as Dr. Lakshmi pointed out. We've also started to use bivalirudin. We've done it in 3 of our patients. 2 of them did very well. All of them had HIT, and bivalirudin is a very good option. Another option in the horizon for HIT is one of the questions which are there in the chat box I just saw, is antithrombin 3. Antithrombin 3 is a drug which, with heparin, which is a prodrug, forms a 1,000 times faster anticoagulant survey. So when you see anticoagulants being used, antiplatelet drugs being used, you must do viscoelastic tests. And bivalirudin as well as argatroban can be very nicely tested if no viscoelastic tests agree with APTT and ACT alone. Next, please. So anticoagulation rope should be tightened as much as possible, even in 2023, not just in 2018 when this article was written by us, but rotem platelet aggregometry helped us bring about these algorithms. I'll skip all this. Can we go to the next, skip the next 10, 15 slides, please? If you can't, because of paucity of time and we are running late, we must implement these, and these are some of the algorithms coming to you. You must have your own institution algorithms, when to give heparin, when to give on the rotem. It's a big class on itself. When you have your A5 and A10 and your MCF, which is the MA, as less or more, what product to give. And this is what I will be talking about with some case scenarios. Next, please, in the next few things. So if you have targeted your normothermia, these are algorithms by us. Next, please go on to the next few ones. So next, please. So we still have only class 1 or 2A evidence of consent for patient blood management on ECMO, because not, as I said, many guidelines exist. And what are our problems? Our problems are these in India. We have a paucity of funding. There's no awareness of ECMO use. ECMO should be a stethoscope, like a stethoscope in every ICU of a hospital. But many people are not aware of it. So education and awareness for the existence of ECMO as a modality, as a palliative care, as a supporter, as a bridge to transplant, as a bridge to recovery, as a bridge to bridge, and as a bridge to nowhere. Wherever we use ECMO, we must use it as fast as possible. While we are on ECMO, not the quantity but the quality monitoring on ECMO is important. Then overcoming resistances to a change. There is a lot of resistance to anything new technology that's coming up, though ECMO is not new. We've been using it since 2002, the ECMO Society of India since 2010, and in 2014 when SWAC was formed. It's wonderful to see how many SWAC have happened in India itself, in Bombay, in Bangalore, in New Delhi, and now in Ludhiana. So ECMO is not new, but ECMO should be adopted eagerly and learned by all of you. Challenges in preoperative anemia management, and also anemia and oxygen balancing with cardiac surgery and outcomes in women should also be seen. When a female patient goes into ECMO, then she can be very well seen on just managing her anemia pre-op and post-op, pre-ECMO and post-ECMO. Next, please. Please go on to the next one. Can I go on to the sonoclot slide? This was SWAC also Reminiscences of 2018, which we held in New Delhi with Dr. Robert Bartlett with us, and our dean, our directors, Dr. Trehan and his team. Everyone was looking forward to this wonderful event with more than 840 delegates. And we released our books and our journal, and I'm sure this is the way that we all learned in India, and you all will learn and do better than us. Next, please. And we go on to the last few. I just want to say that fibrinogen is very important. Single factors are very important. And when we do single factors, be aware that prothrombin factor complex, as well as platelet factor concentrates, as well as fibrinogen concentrates, antithrombin 3 concentrates, NOVO7 3 concentrates, factor 8 concentrates, all these single factors are available. And a report on factor 7A increases the risk of thromboembolic events, and therefore there should be a very, very guarded use of factor 7A in ECMO. This is my concern because we were using it randomly and losing a lot of our patients because of intracranial hemorrhage. So we stopped using factor 7 at all in a bleeding patient on ECMO. It is a myth, it should not be used, is our experience at least of the 40 cases that we did on factor 7A. Next, please. So while we are, you can go on, we had this algorithm from AIMS where we would make the patient hypothermic patient normothermic, do away with the heparin influence by adding more protamine. If there was a protamine overdose, we would buy some time and then remain on low flow ECMO and then go on to high flows. And as we were building up our algorithms, we found that PF-SON, one parameter on sonoclot, the MA on TEG, classical TEG we had used, and the A5 MCF in XTEM and particularly FIPTEM A5 were the best parameters to tell us whether our patient was going to bleed or not. So this, along with platelet aggregometry, I'll just discuss in the next 4 slides. Can I go to the last 10 slides, please? Yeah. So there's a big role of testing. Fresh frozen plasma should be a primary, it's a very primary source of coagulation factors and most common blood components to be used today. 1 unit of fresh frozen plasma has about 200 to 250 ml of plasma. Expiry date is up to 1 year, and you can use it by thawing it at 37 degrees for about 20 to 30 minutes. And once thawed, it can be given or stored for up to 24 hours at 1 to 6 degrees centigrade. Next, please. So giving FFP in most cases, if blood is not available, is a very wise choice. But you must see on a point of care testing whether your patient does require this FFP. Next, please. So when you have cryoprecipitate, this is what is mostly required. This is our experience by our patients, because maybe we do more of VA ECMO on pediatric patients. Our patients on ECMO have a lot of hypofibrinogenemia, especially after day 7, day 8. And we saw that, and we studied cryoprecipitate, that 1 bag of cryoprecipitate, which contains about 250 milligrams of fibrinogen in 15 to 20 ml of plasma, also has cryoprecipitate also has 1 milligram factor. So both deficiency of 1 milligram factor as well as FFP is a very good antidote to a bleeding patient in ECMO as a first choice rather than to give blood if the hemoglobin is 7 and above. So if my hemoglobin is okay and my patient continues to bleed and I don't have blood, I would rather order from my blood bank cryoprecipitate. Give 2 units, give 3 units, repeat the ACT. If you don't have a viscoelastic test, you can send your level for fibrinogen serum levels as well as APTT, do a PT-INR, which may not be so helpful, and neither would a BTCT. But at this same time, remember that hypofibrinogenemia, factor VIII deficiency, as well as uremia going into AKI are very big consequences of prolonged ECMO, and they should be tackled with a CARRT machine with ECMO, the last one, and by giving just plain cryoprecipitate with most of them. Next, please. So platelets are the backbone again, they expire in 5 to 7 days. They can be used in routine blood filters and any DIC and etc. They can be given. Next, please. Dengue patients, we were using platelets, but platelets are again a very good source of bleeding source of giving in bleeding patients instead of blood. RBC transfusion triggers is a term used to describe the set of circumstances in which transfusion is reasonable and which for no further justification is needed. So next, please. So while we are doing transfusion triggers, you have invasive and non-invasive triggers. Just a brief slide on both of them. Next. So when we have these transfusion triggers, remember that, as I said, oxygen balancing, the PVO2 is mixed venous oxygenation, is most important, as is the central venous, as is the oxygen uptake and also oxygen extraction ratios. Next, please. Some of the non-invasive ones which we can do, hemoglobin is a transfusion that is required at a hemoglobin of less than 7 or more than 10. If it is unjustified, it is more than 10, don't give blood. Can you mute your mics, please? And you see the duration of anemia. Next, please. When you're seeing the duration of anemia, it's important to see what the ASA guidelines write for blood component therapy. These guidelines are there everywhere, but I would say whenever there is hypofibrinogenemia, give cryoprecipitate. Whenever there is a microvascular bleeding, with the APTT being deranged, we normally say keep in APTT between 60 to 80. Now, if it is less than 40 and if it is above 80, you must know what to give. And this is very, very important. What to give when your APTT is less than 40 and your APTT is more than 80. Because if it is high, is it thrombosis? If it is low, is it bleeding? You have to see the whole clinical scenario of every individual patient. And that's what's important. Platelets, rarely given when more than 1 lakh, but when less than 80, start preparing for the platelet. Less than 50, please give 2 single donor units over a period of 12 to 24 hours, and you'll see your patient doing well. Next, please. So while we are doing these guidelines, let's remember that aspirin should be stopped where platelets are less than 50 and initiate again if an adult patient needs aspirin when the platelets are higher. Aspirin plus clopid you should give when platelets are more than 400 grams. So more than 4 lakhs, only then give it. Otherwise, withhold these drugs as far as possible. This is very important during ECMO. Next, please. So anticoagulation in ECMO, we've done these. You can skip these slides, please. These have been done. Skip all these. All these, yeah. You can skip all these. There are a lot of these review of literature that says that what to give, but none of them is definitive. But I would like to come to this machine to tell you what to give when we and how we use it in our patients. So functional hemostasis, this is viscoelastic measure, one of the cheapest one available with 2 chambers. You can see one for ACT. You put in a cuvette, it works in a viscoelastic electromagnetic field. A cup and pin move in this electromagnetic field, creating a signature. Next, please. This signature tells you a lot about the heparin. This is the signature on sonoclot. So you can see, unlike the TEG, which has a small clotting time that Dr. Lakshmi was talking about. You have a small ACT, which is the clotting time. And then it starts peaking. This peaking is the platelet aggregating. So this peaking is a measure of your platelet function. And then when the clot is formed, it starts retracting. The slope downwards is your retraction. All of this happens in 15 minutes. It's monitored over a DR15 value, which comes on the side of the computer. This viscoelastic machine is attached to a computer, and this signature curve comes on the computer with normal values coming onto the computer. And you can see your values of your patient and compare it with the normal values given below the box. And you will see on the same screen how abnormal, high or low is your value. So it's as simple as that. Next, please. So in 15 to 20 minutes turnaround time, you come to know a PF SON value, an ACT, which is the CT, then a PF SON, which is the slope high and the peaking, and then a slope down, which is the CRT, the clot retraction time, and a DR15. So just these four values on a sonoclot, and you learn so much. I'll go with examples. Can you give me the next slide, please? So that's a typical normal signature curve. You look out for the peaking. Now the peaking and the ACT coming normal is fine. If it is a straight line, it means it's an effect of heparin. So let's see what happened here. Post-quantum Ecmo 2, 5-year-old child, baseline no peaking, ACT 138, normal. What did we do? We saw it is platelet dysfunction. ACT was 133, the clot rate was 20, and the PF SON was 0.9. So clot rate is, it's not retracting, and your PF SON, it's not peaking. It's less. Normal is 1.6 and above. So when something like this is happening, you know that this patient has a platelet dysfunction. Don't give anything. Just ask your blood bank to arrange 8 to 10 units of single donor platelets, or 4 units of single donor and 8 to 10 random donor platelets of normal PCCs that we call it. Give over a period of 24 hours 8 to 10 such platelet concentrates and see your patient peaking again. Next, please. So you can see this peaking. You can see another patient, total correction, didn't do well, came on ECMO, low cardiotomy, low cardiac output. We put the patient on ECMO. We came off on ECMO. This was the normal. We saw 2 peaks, but not convinced that everything is normal. What are we seeing here? Platelet function should be more than 1.6. My platelet function is very high. It's 2.3. The clot rate should be 9 to 13. My clot rate here is 12.8. It's on the lower side. And ACT is about 164. So when you see such a patient and the DR15 is 75, so all deranged. So when I'm seeing such a patient, I'm not convinced. Next, please. What should we do? This was the baseline, and we gave post-protamine. We saw that all the factors are low. The platelets are low. The factor 8, factor 9 is low. So what should we give to our patient? We were wondering. And we kept thinking. And next, please. And we gave FFP to our patient, and we saw a normal baseline. So next. And FFP somehow should be given as a last resort. Think of cryo for hypofibrinogenemia, which is very beautifully told on a rotum. Platelet dysfunction very beautifully on a sonoclot. And any deficiency, there'll be no peaking. Now here again, there is a broad plateau, and there is a prolonged CT. So this is again a platelet dysfunction. Give platelet concentrates, post-protamine, and your patient will do well. Next, please. So again, another total correction, 24 hours, we saw good normal hemostasis with the peak coming slightly delayed, but it did come. Next. Now, those were sonoclot, which tells us beautifully about platelet function. What about rotum and TEG? Rotum and TEG are again viscoelastic tests. Working in an electromagnetic field, TEG, like sonoclot, uses QX, which are heparin or heparinase, but can I have the next few slides? Yeah, next please. But these are classic slides, and you can see here on the rotum, can I have this for a minute? It has 4 chambers. Here there is no slide, here there are reagents. There are reagents in a cup pin movement. This blue one is what your platelet aggregometry is, and that is your computer which tells you your signals. Can we go to the next one? So here again, 2-3 cases that I wish to discuss. This is your normal rotum curve. Here, what are we seeing? That the FIPTIM level, here it's INTIM, which shows heparin influence. The INTIM with heparinase, if I give heparinase or I give ECA-10, this is the only machine which has ECT for Vivaldi, ECA-10. So this has different reagents which are ellagic acid, calcium chloride with tissue factor. When tissue factor is added, it's extem. When you have extem with cytochalasin D, it is fiptim. This is the fibrinolytic pathway. This is the extrinsic pathway. This is the intrinsic pathway, and this is the heparin pathway, or the ikarin pathway, or the aptem. The aptem is anything to do with arachidonic acid or antifibrinolytics when we use. So those pathways. So depending on the reagent we use, we have these four signatures coming on our screen. So you can see heparin influence with a flat intent. Next, please. And here the L's are normal. And here again, you have normal and abnormal screens at the bottom. Now, in this case here, we saw the fiptum as a flat line. The amplitude, the MCF was low, also low in extem. And when you see extem and fiptim which work together, these low, it means it's fibrinogen deficiency. So this is a very good machine to tell you about hypofibrinogenemia. There's low amplitude, there's low fibrinogen, and this is seen in intim and extem due to fibrinogen deficiency. So there's no hyperfibrinolysis here. So what will I give to my patient? I'll give cryoprecipitate. I will not think of blood. So what to do when was what I was asked. I would not ask for PRBCs. I would not ask for leukocyte depleted blood or platelet concentrates. I would just ask for 6 to 7 units of cryo. Depending on the blood group, cryo doesn't need a particular B positive, can be given any group, blood group. It should not be just negative. That factor should be kept in mind. Any positive blood group. So you give cryo, and you should remember that cryo should, if it is not used, it should be kept in a fridge at 4 degrees centigrade or lower, because if once it is thawed, it has to be given immediately. So that is one drawback of both cryo as well as platelet concentrates. Next, please. So we had another case here is of a typical hyperfibrinolysis, which you see very beautifully on TEG also. And you don't see something like this so beautifully on sonoclot. So sonoclot for platelet dysfunction, for any heparin influence, but here for any antifibrinolytic given where your lysis is cut short before 30 minutes, and this it is there in all three. And the moment you give antifibrinolytics, the aptem pathway, you've given here tranexamic acid, you can see it is a normal one. So hyperfibrinolysis as well as hypofibrinogenemia very well on a rotum. Next, please. So let's see a case. You could next, please. Please skip these. We have 4 case scenarios. Agatroban is coming up in a big way, and you can skip all these slides, please. Can you come to the last 5, 6 slides where you have rotum studies? Yeah. After this. Yeah. This one. Yeah. Thank you. So here you have a VA ECMO patient who was bleeding in the ICU post arterial switch operation. We were using integrated ECMO. This patient was an ECMO. And over a period of 24 hours, the small child oozed something like 3 liters of blood and was tamponading, decreased cardiac output. Now here the rotum shows a fiptum, which is again a MCF is less than 2 millimeters, and an extem again is very less than 28, and these parameters come on these boxes. But here we've done a platelet aggregometry, which is there from the blue box. So you attach 2 indicators, extem, fiptem, and you've attached a ADATEM and a EDP10. This takes care of your adenosine pathway, which is for clopid, and ADATEM takes care of your arachidonic acid pathway, which is for aspirin. So you have 3 of them, the thrombin pathway, which is traptem. You can choose your reagent depending, and we did this here. The platelet function is normal. Normal area under the curve, normal A6, normal spine slope. But here the MCF is low. So again, a case of hypofibrinogenemia. We saw and we calculated how much units of cryo the patient would need. The company gives you a normogram, how to calculate depending on the fiptum values and the extem values, how much of cryo to be given. Next, please. And we calculated, and we saw that according to these calculations, fiptomatin was less than 2 millimeters, and the desired value that we want is 8 to 9 millimeters. So as per the table here, we needed, according to the body weight of the patient, about 15 units of cryoprecipitate, and we gave it over 24 to 36 hours slowly, and our patient did wonderfully well without needing a re-exploration. The tamponading effect went away. We didn't have to open the chest, and the patient did well. So you have to make the surgeons and the intensivists believe that, okay, this modem exists, and this modem tells us in a shorter turnaround time. And I can, when my APTT and fibrinogen reports came, I was very happy because my APTT here was less than 40 and my fibrinogen was more than 4. So I know that less than zero 0.5 here. In another patient, it was more than 4. I'm confusing. So my fibrinogen was less and my APTT was less. So giving precipitate was the best answer. Next, please. Another patient, after giving 50 units of cryoprecipitate, this was the rotum. So 3 tests, roughly 8,000, and 2 tests done fibrinogen and APTT from the lab, we were good to go. Next, please. I'll just do one more case and shortage of time. Just because I'm last, I'm going on. There's a post-op patient of CABG who was a off-pump CABG, and you see a typical hyperfibrinolysis. Here, the fiftum is a flat line, but what is happening here? There is a platelet which is less area under the curve, and with less area under the curve, it's important that the platelet dysfunction is seen along with antifibrinolytics needed because of hyperfibrinolysis. So this is a typical case of hyperfibrinolysis with decreased platelet function. Give to this patient platelet concentrates now and give 4 to 5 concentrates fast. You can give platelet concentrates fast if the blood pressure is maintained. The mean arterial pressure above 60 at all times. Next, please, will give us these results. So these are our cases where we saw hyperfibrinolysis, and it said normal platelet function, though it was less. We just gave tranexamic acid and some platelets both, and we saw patients do well. Next, please. So this is how the platelet function also improved with tranexamic acid given high dosage, 25 milligram per kg as a single bolus. Next, please. Another patient post-ventral continues to drain for 7 hours, no effect of any blood product. We'd given PRBCs, we'd given FFP, we'd given PC and cryo, but no effect, and we'd given antifibrinolytics. What did we find here? We found in intim there is a prolonged CT. Okay, so it means the clot formation is not right. Then we saw also in interim that the MCF is less. The heptum CT is very normal and flat line in the platelet functions here. Right? So this is a frank case of low platelet functions. There is no platelet to form the clot. The MCF is low. So this is a case of heparin influence also with decreased platelet function. And because the heptum became normal, and it was a flat line there. And when we gave protamine and we gave interim CT became normal, the bleeding was due to overdose of heparin and also due to deranged platelets. So give 2 units of platelet and give an antidote of protamine and see your patient do well. And this is what we don't do. We don't give protamine because we overlook the residual heparin influence. I think I can end here and go to my conclusion slide. After giving these tests, I hope it's very clear that you don't need to give so much of packed red blood cells. Maintain your hemoglobin targets. You need to give a lot of cryoprecipitate and platelet concentrates to your patient. FFP should be one of the last resorts when all factor deficiencies exist. And if hemoglobin goes down to less than 7, there's no shortcut. Give at least 3 to 4 units of leukocyte depleted red blood cells. But we need someone to give us an algorithm on what to use when, and I'm sure some future randomized control trials will bring about that. Perioperative red blood cell transfusion is associated with the worst prognosis on Ecmo patients. Optimal perioperative management and restrictive transfusion might be considered in selected patients. Remember, preoperative anemia, especially in children and women, should not be overlooked, and perioperative as well as postoperative anemia should be managed. Whether you manage it with iron, whether you manage it with erythropoietin, whether you manage it with diet or you manage it with red blood cell transfusion on an ECMO, diet has less of a role for managing anemia. But erythropoietin has been given in scattered case reports, and as has a lot of patients who have given blood transfusions. But optimize the anemia, and that's very important. Last, please. Another variable that might confound the transfusion threshold is the possibility of heart or lung transplant, in which case a restrictive transfusion likely will be selected and should be selected to minimize antigenic burden and the risk of antibody formation. This is also a risk. It is an antibody forming thing, and so is lung transplant and cardiac transplant. Large variability in blood products management between centers which might exist, which might result in lack of scientific recommendations, and this is what we suffer from for blood transfusions, how and when in ECMO. Thank you all. I would like to invite you all to SWAC also 2023. The first slide got deleted. Next, please. Next, please. And you'll soon be seeing a grand feast. Online TSS fellowships on ECMO are on. Anyone who wants to enroll can enroll and become a member of the same. We have a lot of books. We have trained more than 1,400 ECMO students in the last 5 years. And this year we have just a few limited seats left. Anyone wants to enroll for ECMO, most welcome. Thank you, Vivek, and thank you, the organizers, for giving me this opportunity. And I wholeheartedly apologize, especially to Dr. Khurana, for making him suffer because of my slide not working. Sorry, Henry.
Thank you. Thank you for the excellent talk. Ma'am, we have one question. How reliable is methemoglobin for hemolysis?
Pardon? How do you monitor methemoglobin?
How reliable is methemoglobin for hemolysis?
Well, methemoglobin studies on hemolysis were done in around 2008-9 when methemoglobin was becoming a culprit for cyanide poisoning. We were looking at methemoglobin formation, but methemoglobin levels are again difficult to do. Just as you have difficulty in doing even an APTT in a normal laboratory, even like ours, we have to send the blood across to the other building. So methemoglobin and methemoglobinemia does bring about hemolysis, but measuring methemoglobin levels is a difficult, ardent task. But the sensitivity, once methemoglobin is detected, the sensitivity towards hemolysis is as high as 90%. So if you have a laboratory which can measure methemoglobin, then above the normal levels of methemoglobin, if they exist, then hemolysis is a sure shot way. But hemolysis index and most of the targets today don't talk of methemoglobin because it is a rarity, and it's the way it is calculated is also done in very few labs.
Okay.
Any
Thank you,
other
ma'am.
questions?
There are no more questions.
Thank you.
Thank you, ma'am. So we can end it here. Sorry, ma'am?
I said good luck for tomorrow. I hope you have no. Thank you.
Thank you, ma'am. Thank you, ma'am. So we can end the session here tonight, and we'll continue with the session tomorrow from 5 p.m. Thank you, everyone, for attending this session. Hope to see you tomorrow again. Thank you.